So think about when you go out to buy a car. You look at the sticker price, you negotiate a little bit, sign the paperwork, and you know exactly what you're paying.
Right. Yeah, it's totally linear. It's a standard, transparent transaction.
Exactly.
The terms are all set up before you get the service, and both parties walk away knowing exactly what the financial exchange was.
But if you step into an American emergency room, that whole predictable model it completely evaporates.
Oh, absolutely.
You're suddenly dropped into this labyrinth where, like, the price tags are completely hidden and the rules change depending on literally what door you walk through.
Yeah, and the bill doesn't even arrive until weeks after you've already gotten the care.
Which is wild. And this isn't just some, theoretical inconvenience we're talking about today.
And not at all. I mean, today's source material highlights a reality that we really need to confront right at the top. Medical debt is literally the #1 cause of personal bankruptcy in the United States.
Number one.
Wow. Number one, we're talking about a system where a single uninsured visit to the ER just for something like a sudden pain in your stomach can generate a bill anywhere between $5,000 and $50,000.
$50,000 just for like an unexpected Tuesday evening.
Yeah, it's absolutely staggering.
That is just terrifying. Yeah. So for you listening, we're looking at a fascinating educational script today. It was originally designed to teach advanced English learners and newcomers, basically a survival guide to the mechanics of the U.S. healthcare system.
Right. It's a literal survival guide.
And our mission for this deep dive is to extract the absolute most crucial, practical nuggets of knowledge from this text.
Yeah, whether you're, prepping for a move to the U.S. or maybe you're just trying to figure out your own benefits at a new job.
Or honestly, even if you're just insanely curious about how this massive infrastructure actually operates, this deep dive is going to be your shortcut to becoming fully well-informed.
Now, I should clarify something really quickly. There is obviously endless, passionate debate globally and domestically about whether this specific system is broken or brilliant, moral or immoral.
Oh, for sure. A huge political talking point.
Right. But we are putting politics completely aside today. We aren't here to debate the philosophy of American healthcare.
Yeah, no taking sides here.
Exactly. Our only goal is to act as your guides, to show you the board, explain the rules of the game exactly as they're currently written, and, teach you how to play so you can protect your physical health and your financial future.
Okay, let's unpack this. Because to understand how a single hospital visit can financially ruin someone, we first have to understand the foundational architecture of the U.S. system.
Yeah, you have to start the foundation.
Because if you're coming from outside the U.S., your instinct is just going to be incredibly misaligned with reality.
That is the core issue for most newcomers, honestly. I mean, if you look at countries with universal healthcare models, the ones funded broadly by taxes, the healthcare system essentially acts as a public utility.
Right, like the fire department or roads.
Exactly. Everyone pays into the tax base, and everyone is covered. But the United States does not have a single-payer system. It relies heavily on a fragmented private insurance model.
So instead of one big safety net, there are basically 4 main channels that you can use to get health insurance.
Yeah, 4 main channels. And your access to care depends entirely on which channel you happen to be standing in.
So let's map out those 4 distinct pathways. The first one, and by far the most common, is employer-sponsored insurance.
Right.
According to the source, this channel covers roughly 49% of Americans. That's about 160 million people.
Yeah, the mechanics of this are just deeply intertwined with corporate America. Yeah. When you get hired for a full-time position at, say, a medium to large company, they typically offer a health insurance plan as part of your compensation package.
It's not free, right?
No. Definitely not free. The employer pays a portion of the monthly cost, and then you pay the remainder. And this is done through what's called a payroll deduction.
So the money just comes out of your paycheck before you even see it?
Exactly. The funds are extracted before they ever hit your bank account.
Which kind of makes it feel invisible, in a way. I mean, you get the job, you sit through the HR orientation, you check a box, and suddenly you're in the system.
Right. Your paycheck is just a little lighter than your stated salary, and you don't really think about it.
But what happens to the other 51% of the country? Like people who are freelancers, gig workers, small business owners?
Well, that brings us to Channel 2, which is the health insurance marketplace.
Oh, right. often referred to as the ACA or Obamacare.
Yeah, exactly. This is a government-regulated marketplace where individuals can purchase private insurance. Now, to make this affordable, the system features subsidies for households making between 100% and 400% of the federal poverty level.
Okay, so the government basically gives you tax credits that instantly lower your monthly bill.
Yes, but, and this is a really massive, but this marketplace is rigidly structured around time.
Wait, what do you mean by structure around time?
Well, they have to prevent people from waiting until they get sick to buy insurance.
Ah, right. The concept of adverse selection. Because if you could just buy insurance on the way to the hospital, the whole financial model would completely collapse.
Precisely. So the system locks the doors. Enrollment is strictly limited to an open window from November 1st to January 15th.
Wow. So you can't just decide in, like, April that you want to buy health insurance on the marketplace.
Nope. You are entirely locked out until the following November.
Unless you have what the system calls a qualifying life event, right?
Right, yes. This is crucial for anyone moving or changing jobs. If you get married, have a baby, lose your existing employer coverage, or physically move to a new state, you are granted a special temporary window to enroll.
Okay, that makes sense. Then we have the final two major channels, which serve as the government-funded safety nets, Medicaid and Medicare.
Yeah. So Medicaid is designed for low-income individuals and families, but eligibility is incredibly complex.
Because it varies by state, right?
Wildly. A person who qualifies for Medicaid in New York might be completely denied in Texas just based on state-level legislation.
That sounds super confusing. And then Medicare is the federal insurance strictly reserved for citizens aged 65 and older, plus some people with specific long-term disabilities.
Correct. Oh, and for any international students listening, the source brings up a really critical side note. Universities often offer their own isolated channel called SHIP.
Student health insurance plan.
Yes. And the text explicitly warns students to read the fine print on those policies. SHIPs can sometimes have massive, dangerous blind spots.
Really? Like what?
Particularly when it comes to covering chronic pre-existing conditions or comprehensive mental health services.
Oh, wow. Good to know. So looking at these four channels, employer, marketplace, Medicaid, Medicare, the immediate realization is that the U.S. system isn't a single cohesive grid at all.
Not at all.
It's more like this ecosystem of highly siloed subscription services. Like you have a corporate subscription, an indie marketplace subscription, a senior subscription.
That's a great way to think about it.
But how does someone avoid falling through the cracks if they transition between these subscriptions? Say you get laid off from that corporate job on a Wednesday.
If we connect this to the bigger picture, you are touching on the defining vulnerability of American healthcare. Health security in the U.S. is intrinsically tied to your employment status.
Yeah, they are totally linked.
When you lose your job, you don't just lose your income, you often lose your healthcare channel simultaneously. You're immediately thrust into the ACA marketplace under a qualifying life event, and you have to scramble to set up a new subscription.
While dealing with the stress of unemployment, that's rough. But what if you just, don't? What if you look at the prices on the marketplace and decide to risk it?
Well, historically, you would face a tax penalty. But a crucial piece of knowledge here is that the individual mandate penalty, the federal fine for not having insurance, was reduced to $0 in 2019.
Wait, really? $0? So from a legal standpoint, no one is going to knock on your door, arrest you, or fine you for being uninsured.
Exactly, meaning it is completely legal to just walk away from the ecosystem.
Wow.
It is legal, but voluntarily opting out carries an almost incalculable financial risk. I mean, you're stepping onto a tightrope without a net in a country where the raw cost of medical services is inflated to a degree that's just hard to comprehend until you receive your first bill.
Which brings us to the actual math of getting sick. Because securing your insurance, picking your subscription, is really only the prelude.
Right, it's just step one.
The source identifies a massive, dangerous misconception that trips up newcomers and honestly even lifelong citizens. People assume that once they have that plastic insurance card in their wallet, their medical care is going to be free or at least heavily subsidized from day one.
I would argue it is the most dangerous assumption a patient can make.
Absolutely.
In a universal system, you present your card at the clinic and you walk out. The transaction is handled on the back end by the state.
But in the U.S.?
In the U.S., having an insurance card merely means you are allowed to play the game. It does not mean the insurance company is paying your entry fee for every single ride.
Yeah, so we have to decode the specific vocabulary of out-of-pocket costs. Because if you don't understand the mechanisms behind these words, you will be financially blindsided.
Definitely. Let's break down this vocabulary because the terms really build on each other. Term number one is the premium.
Right. This is your baseline monthly membership fee. You pay this every single month to the insurance company, regardless of whether you visit the doctor 50 times or 0 times.
Exactly. It's a sunk cost just to keep the contract active. And the mechanism behind the premium is risk pooling. Your monthly fee goes into a massive pot to pay for the care of everyone in your network.
But paying that premium does not shield you from additional costs, right?
No, not at all. Which brings us to term number two, the deductible.
This is the one that causes the most shock. The deductible is a specific dollar amount that you must pay 100% out of your own pocket before your insurance company steps in to cover anything significant.
And these are not small numbers we're talking about. The source notes that deductibles typically range from $500 to upwards of $5,000 or more per individual per year.
Okay, let's put a scenario to that to show how the mechanism works. Say I have a $2,000 deductible. It's January, I slip on the ice, break my arm, and receive a hospital bill for $3,000.
Okay, so because you haven't met your deductible yet, you are responsible for paying those first $2,000 entirely by yourself.
Wow.
The insurance company pays absolutely zero of that initial chunk.
They literally just sit back and watch you pay. And then only after you cross that $2,000 finish line does the insurance finally wake up and start helping.
Exactly.
But, and here is term number 3, even after you beat the deductible, the care still isn't free. You enter the phase of co-pays and co-insurance.
Right, because the insurance company does not want to take on 100% of the financial burden, so they enforce cost-sharing mechanisms. A copay is a fixed, flat fee.
Like when your plan says, every time you see a primary care doctor, you pay a $30 copay at the front desk.
Yeah, exactly. Co-insurance, however, is far more volatile. It is a percentage split between you and the insurer.
The classic example in the text is an 80-20 co-insurance split, right?
Yes. The insurance pays 80% of the bill and you pay 20%. Now, 20% sounds completely reasonable on paper.
Right. 20% doesn't sound too bad.
But let's apply that to American medical pricing. If you end up in the ICU for a week and the hospital bill is $100,000,
oh no.
Your 20% coinsurance means you owe $20,000 out of pocket, even though you already paid your premiums and you already paid your deductible.
That is horrifying, which is why the system has to have a fail-safe. Otherwise, literally every major illness would result in guaranteed bankruptcy, even with insurance.
Exactly. And that fail-safe is term number 4, the out-of-pocket maximum.
This is the absolute legal ceiling. The out-of-pocket maximum is the maximum amount of your own money you can be forced to spend on covered medical care in a single calendar year.
Right. So let's say your maximum is $8,000. Once you hit that ceiling through a combination of paying your deductible, your co-pays, and your co-insurance, the insurance company finally covers 100% of your costs for the rest of the year.
It acts as an absolute stop loss for your bank account.
It does. And the mechanism of why this entire structure exists, the deductibles, the co-insurance, comes down to an economic concept called moral hazard.
Moral hazard. How does that work here?
Well, insurance companies believe that if healthcare is entirely free at the point of service, patients will overutilize the system. They'll go to the emergency room for a paper cut.
Ah, I see.
By forcing you to pay a deductible and co-insurance, the insurer is forcing you to have skin in the game. They want you to feel the financial sting so that you think twice before seeking expensive care.
I have to frame this out-of-pocket journey using a video game analogy. Because when you lay it all out like that, it's exactly like leveling up.
Oh, I like this. Go ahead.
Okay, so paying your monthly premium is just buying the gaming console. You have to buy it to play, but it doesn't beat the game for you.
Right.
Then the deductible is the incredibly difficult, brutal first level that you have to beat entirely on your own, using your own health and your own money.
Yeah, no help from the game there.
Exactly. Once you finally beat level 1, copays and co-insurance are like unlocking co-op mode, where the insurance company finally picks up a second controller and helps you fight the bosses.
Okay, I see where this is going.
And if you survive long enough, take enough damage, and spend enough money, hitting the out-of-pocket maximum is achieving invincibility mode. You glow brightly, you take 0 financial damage for the rest of the calendar year.
That is a phenomenal analogy.
But then, on January 1st at midnight, the server resets, your progress is wiped, and you wake up right back at level 1. staring down a brand new deductible.
It really highlights the exhaustion of the cycle. And, understanding that grueling cycle explains why the source text spends so much time dissecting a very specific strategy, the HDHP, or High Deductible Health Plan.
Oh, right. Let's dive into the HDHP, because you can intentionally choose a plan with an aggressively high deductible, say $6,000, in exchange for a much lower monthly premium.
Yes. And the text notes that you can pair this HDHP with an HSA, a health savings account.
And the HSA is this unique tax-advantaged vault, right?
It is incredibly powerful. The HSA is universally touted by financial planners as a triple tax-advantaged account. The money you put in lowers your taxable income, the money grows tax-free, and you pay no taxes when you take it out for medical expenses.
And it never expires. It rolls over year after year. And once you turn 65, you can withdraw it penalty-free for non-medical expenses, basically treating it like an extra retirement fund.
Exactly. It's a huge financial tool.
But I have to push back here, because looking at the mechanics we just outlined, isn't an HDHP essentially just gambling on your own biology? I mean, you're accepting a massive, terrifying deductible in exchange for a tax shelter.
I wouldn't just call it a gamble. I mean, for a healthy 25-year-old who goes to the doctor once a year for a checkup, it is an aggressive, calculated wealth-building strategy. You're banking that tax-free money and letting it compound.
Right, if you never get sick.
But the nuance here is that the line between a savvy financial investment and total financial ruin is incredibly thin. It is exactly one bad car accident or one unexpected chronic diagnosis.
Oh, I see.
If you choose an HDHP and suddenly develop diabetes in February, you are immediately on the hook for that $6,000 deductible before the co-op mode ever activates to help pay for your insulin. It requires immense liquidity and risk tolerance.
Okay, so we've mapped out the predictable math. You choose a strategy, you save up for your deductible, you understand your coinsurance percentages. But the source warns that even if your spreadsheets are perfectly aligned, the U.S. system features hidden traps that can completely bypass your math and upend your life.
Yes. Mastering the out-of-pocket maximum gives you a false sense of security, because that maximum only applies if you follow the invisible geographic and contractual boundaries of the system. We are moving out of the predictable math and into the true danger zones.
And the most perilous of these danger zones is the concept of networks.
Exactly. In the United States, an insurance company does not simply pay any doctor you choose to visit. They act as negotiators.
Okay, so they go to specific hospitals, specific labs, and specific physicians, and they negotiate bulk discount rates.
Right. And these contracted providers become your in-network ecosystem. If you stay within that ecosystem, your deductibles and out-of-pocket maximums function exactly as we described.
But if you step outside of those boundaries and visit an out-of-network provider, the protective math just vanishes.
Completely vanishes. The insurance company provides virtually no coverage, the rates are dramatically, punitively higher, and whatever you pay often does not count toward your out-of-network deductible.
And you might think, well, that's easy. I just won't drive to an out-of-network hospital. But the text outlines a structural flaw that is the stuff of actual nightmares. It's so common it even has a name.
Yes. The anesthesiologist nightmare. Let's walk through a hypothetical patient experiencing this to understand the exact mechanism of how this trap springs.
Okay, imagine you tear your ACL and need knee surgery. You're a diligent patient, you do everything right.
But you do your homework.
You call your insurance, you carefully select an in-network hospital. You research and find a highly rated in-network orthopedic surgeon. You confirm everything.
So far, so good.
You show up on the day of surgery, you're wheeled into the operating room, and you go to sleep thinking your financial exposure is strictly limited to your out-of-pocket maximum.
But here is the structural flaw. Hospitals in the U.S. do not necessarily employ everyone working inside their building.
Right. The anesthesiologist who walks into your room to administer your medication happens to be an independent contractor. Their specific private practice has not signed a contract with your specific insurance company. They are out of network.
And you had no choice in selecting them. You didn't interview them. You were literally unconscious.
The surgery is a success. You go home, and a month later, you open your mail and find a surprise bill, technically called a balance bill, for $15,000, generated solely by the anesthesiologist.
Because they are out of network, they simply bill you for the balance that the insurance refused to pay. It is an absolute horror story of bureaucracy, and for decades, it bankrupted people who did absolutely nothing wrong.
That is just terrifying. Now, the source does highlight a recent vital piece of federal legislation called the No Surprises Act, which took effect in January 2022.
Yes, thank goodness for that. This law explicitly bans this type of ambush billing in emergency situations, and for most ancillary services like anesthesiology or pathology provided at in-network facilities.
It basically forces the out-of-network doctor and the insurance company to enter an arbitration process to figure out the payment, effectively removing the patient from the crossfire.
Exactly. It is a massive shield for consumers. However, we must be very clear. The No Surprises Act primarily protects you in emergencies and specific hospital scenarios.
Oh, so there's a catch.
For planned, routine outpatient care, say, deciding to use an out-of-network physical therapist or sending your blood work to an out-of-network lab vigilance is still entirely your responsibility.
Which brings up the next major danger zone, navigating an actual medical crisis. Emergency rooms versus urgent care.
This is a big one.
If you panic because your child has a fever of 102 and you rush to the emergency room, it is going to cost you between $1,000 and $3,000 just to walk through the sliding glass doors and have a doctor look at you.
Just to walk in.
And if they run scans, it scales up to $20,000 instantly. But an urgent care clinic like a walk-in center in a strip mall costs maybe $100 to $300.
The cost disparity is astronomical. And the reason for this comes down to the mechanism of overhead. An emergency room is a massive trauma center. They have to be staffed 247 with neurosurgeons, MRI technicians, and specialized equipment ready to handle a multi-car pileup or a gunshot wound at 3 a.m.
That makes sense. The overhead to maintain that readiness is staggering.
Right. So when you walk in with a sprained ankle, your bill is indirectly subsidizing the astronomical cost of keeping that trauma center operational. Urgent care clinics, on the other hand, only handle non-life-threatening issues. Sprains, the flu, minor cuts. They close at 8 p.m. and they have very low overhead.
It requires you to medically triage yourself before you seek help. But what if you were uninsured or out of network and you were having a legitimate heart attack? Are you just turned away at the door?
This is where we must discuss EMTALA, the Emergency Medical Treatment and Labor Act. It is one of the most critical federal laws in the entire system.
How does it work?
Under EMTALA, any hospital that accepts Medicare, which is virtually all of them, is legally forbidden from denying emergency care based on your ability to pay, your citizenship status, or your lack of insurance. If you are experiencing a medical emergency or active labor, they must assess and stabilize you, period.
That is a massive relief to know. It guarantees that you won't bleed out in the waiting room just because your credit card declined.
True, but EMTALA mandates stabilization. It doesn't mandate free care. The bill still comes later.
Right. You survive, but you still pay. So balancing that reality against the constant threat of out-of-network providers, I have to ask, based on the source's advice, is the practical guidance here actually to interrogate every single medical professional who walks into your hospital room?
Pretty much.
Am I supposed to halt a doctor who is holding a syringe and demand to see their network credentials?
As jarring and deeply uncomfortable as it sounds, yes. The golden rule established by the source is document everything.
Document everything.
Because the system operates as a fragmented marketplace, you are forced to act as an aggressive project manager for your own physical care. You must explicitly ask, are you in network with my specific insurance plan? And ideally, you get that in writing before any non-emergency procedure begins.
That sounds exhausting.
It is. And this raises an important question, though. How is a patient who is in intense physical distress, heavily medicated, or perhaps navigating a severe language barrier, supposed to effectively execute the duties of a corporate compliance officer?
They really can't. Which is exactly why the system feels so punishing. It demands perfect administrative execution from people who are at their most vulnerable.
Exactly.
And if avoiding the financial ruin of the ER means you have to navigate routine preventative care perfectly, then we need to talk about the gatekeepers of this medical ecosystem. Because stepping into the system isn't just about finding an in-network doctor. It is about who actually grants you permission to receive care.
Yeah, we are moving into the daily logistics now. And the primary gatekeeper in the American system is the PCP, the primary care physician.
Whether they are an internal medicine doctor or a family practitioner, they are your required first point of contact for almost every ache and pain.
And your relationship with your PCP changes drastically depending on the specific acronym of your insurance plan. The text highlights the major difference between an HMO and a PPO.
Let's say you wake up with a weird, suspicious mole on your arm, and you want to see a dermatologist.
Okay, if you have an HMO, a health maintenance organization, you are strictly bound by the chain of command. You absolutely must schedule an appointment with your PCP first.
Right.
They look at them all, and if they agree it needs a specialist, they write a formal electronic referral granting you permission to see the dermatologist. If you skip the PCP and go straight to the dermatologist on your own, the HMO will pay exactly $0 for that visit.
Wow. But if you have a PPO, a preferred provider organization, you have the flexibility to bypass the chain of command entirely.
Exactly.
You notice the mole, you look up an in-network dermatologist, and you book the appointment yourself. No referral required.
The trade-off of that flexibility, as always, is financial. I'd love to hear how you conceptualize this difference, because the mechanics can get dry.
The analogy I always use is the museum tour. And HMO is like signing up for a guided museum tour. It is significantly cheaper, but you must stay with the tour guide, your PCP, at all times. They dictate which rooms you are allowed to enter and in what order.
That's a great way to put it.
A PPO is like buying the all-access VIP pass. You can wander into any room you want whenever you want, but you are paying top dollar for the lanyard.
And understanding why the HMO is cheaper is actually fascinating. It's based on a financial model called capitation.
Capitation.
Yeah, the insurance company pays the PCP a flat monthly fee per patient, regardless of how often you visit. The PCP is financially incentivized to keep you healthy, manage your minor issues in-house, and avoid sending you to expensive specialists unless absolutely necessary. It controls the flow of money.
Oh, wow. So it's a strict cost containment strategy. Now, another major layer of this ecosystem, where cost containment creates intense friction, is the pharmacy. It is no secret that pharmaceutical drugs in the U.S. are vastly more expensive than anywhere else in the developed world.
Definitely. And to manage this staggering expense, insurance companies utilize a mechanism called a formulary.
Right, the formulary. That sounds like a spell book, but it's basically a highly restrictive, tiered list of approved drugs. Tier 1 are your generic medications. These are cheap, maybe a $5 copay.
Yeah.
Tier 2 are preferred brand name drugs, which are pricier. And Tier 3 or Tier 4 are specialty biologic drugs, which can carry exorbitant coinsurance costs.
The friction occurs when your doctor, utilizing their medical expertise, prescribes a medication that simply isn't on your specific insurance company's formulary list.
When that happens, you hit a bureaucratic wall called prior authorization. Essentially, your doctor has to pause your treatment, fill out a mountain of paperwork, and beg the insurance company for permission to use that specific drug.
It's awful. They have to medically prove to an insurance administrator that the cheaper Tier 1 alternatives won't work for your specific biology. It is a maddening process that can delay critical treatments for weeks while the doctor and the insurer argue over fax machines.
It is deeply frustrating for both patients and physicians. However, the source does offer some powerful, practical, cost-saving hacks to navigate the pharmacy counter.
First, you should always explicitly ask your doctor or pharmacist if there is an FDA-approved generic available. Generics are chemically identical to the brand name, held to the exact same safety standards, but cost a fraction of the price.
Right. Second, you should utilize tools like GoodRx. This is a fascinating mechanism.
Yep.
GoodRx is an app that essentially acts as a massive discount network.
Yeah, you just type in your medication, and it gives you a coupon code to show the pharmacist.
You completely bypass your insurance, paying a direct cash price that is shockingly often lower than your insurance copay would have been. And third, if you are prescribed a massively expensive Tier 3 specialty drug, look directly at the pharmaceutical company's website for patient assistance programs.
Yes, they often have hidden portals where they will heavily subsidize the drug for middle to low income patients.
These are vital tools to keep your out-of-pocket costs manageable. But as we map out this ecosystem of doctors and pharmacies, we have to address what is undoubtedly the most peculiar, jarring structural oddity in the entire American healthcare landscape.
Oh, I know where we're going.
And that is the literal fragmentation of the human body. Because here's where it gets really interesting.
It really does.
If you read the fine print of an American health insurance policy, you will discover that in the eyes of the insurance industry, your teeth and your eyes are apparently not considered part of your medical body.
It is a profound, almost absurd compartmentalization. Your standard, expensive medical insurance policy simply does not cover routine dental care or routine vision care. You are required to purchase completely separate, standalone policies for your mouth and your eyes.
And calling the dental policy insurance is almost a misnomer. The text points out that a standard dental plan typically has an annual maximum payout of maybe $1,000 to $2,000.
Right.
That is the exact opposite of medical insurance, which has an out-of-pocket maximum to protect you from catastrophic costs. With dental, the insurer caps their own exposure. If you need a single root canal and a crown, that can easily cost $3,000.
Yeah, one bad tooth, and your dental insurance has hit its limit, tapped out, and abandoned you for the rest of the calendar year.
It functions much more like a prepaid coupon book than actual risk-shielding insurance. And vision plans are similar. They're quite cheap, maybe $10 to $20 a month. But they only cover the mechanical optics, like a routine eye exam to check your prescription and a subsidized pair of glasses or contacts.
But if the optometrist looks in your eye and discovers an actual medical disease like glaucoma or a detached retina, they can't treat it under the vision plan. The billing suddenly kicks back over to your standard medical insurance.
It's madness. Why is the body carved up like this?
Well, if we look closely at the history of these professions, this fragmentation is the result of 19th century guild disputes.
Wait, really? The 1800s?
Yeah, back in the 1840s, physicians were organizing and forming groups like the American Medical Association. They viewed themselves as elite scientific diagnosticians. They looked at dentists and optometrists and categorized them as mere mechanics or tradesmen who just pulled teeth and ground glass.
Wow.
Medicine formally excluded dentistry from medical schools, so the professions grew up entirely separately with their own schools, their own lobbying groups, and eventually their own separate insurance models.
A 150-year-old turf war is the reason I have to carry 3 separate plastic cards in my wallet today. That is incredible.
It really is.
And because dental insurance has such absurdly low annual maximums, taking preventive dental care seriously, flossing daily, getting your basic twice-a-year cleanings is not just a health issue. It is a critical financial strategy in America.
Absolutely.
Preventing a cavity is financially equivalent to avoiding a minor car accident.
Exactly. Prevention is the only true shield. Oh, and one quick modern addition to navigating routine care that the source heavily emphasizes is telehealth.
Yes, post-COVID, this has become a massive, efficient staple. Services like Teladoc or ZocDoc allow you to do a secure video visit with a physician. It is an amazing hack for minor, easily diagnosable issues like a sinus infection, a pink eye flare-up, or a basic rash.
And the best part is the transparency. A telehealth visit often costs a flat rate of around $75, even if you don't use insurance at all. You bypass the waiting room, you bypass the network confusion, and you get a prescription sent to your pharmacy in 10 minutes.
It is a highly efficient relief valve for this system. But all of this mapping, the mechanics of deductibles, the gatekeepers, the fragmented policies, ultimately leads us to the final and perhaps most vital section of our deep dive, the human element.
Yeah, this is so important.
Because all the spreadsheets in the world don't matter when you are actually sitting in the sterile room in a paper gown or staring at a confusing piece of mail. Navigating those moments successfully requires adapting to a very specific American cultural approach.
This is huge, especially for international listeners. The source dives deep into the cultural dynamics of the doctor-patient relationship in the U.S. In many cultures around the world, medicine is strictly hierarchical and deeply paternalistic.
Right?
The doctor is an unquestioned, exalted authority figure. They enter the room, they speak, you listen quietly, and questioning their judgment is considered deeply disrespectful or even combative.
But the U.S. utilizes a radically different approach called the patient-centered or shared decision-making model. American doctors genuinely expect collaboration.
They view you as a partner in your own care. They expect you to ask pointed questions about the side effects of a drug. They expect you to check if the cost of a procedure. And they actively encourage you to seek second opinions for major diagnoses.
If you bring that hierarchical instinct into an American clinic, if you sit silently, nodding politely just to show respect, the doctor might assume you fully understand and enthusiastically agree with a highly complex, expensive treatment plan that you actually do not comprehend at all. You have to speak up.
Which directly extends to how you communicate and describe physical pain. In some cultures, stoicism is highly valued. You endure pain quietly, you don't complain, you downplay your suffering so as not to be a burden.
But if you are stoic with an American doctor, you are going to be sent home with a bottle of Tylenol when you actually need an MRI.
Exactly. American doctors rely heavily on a standardized diagnostic framework called Descartes. It stands for onset, location, duration, character, aggravating factors, relieving factors, timing, and severity.
They need explicit granular data. You have to confidently say, the pain started Tuesday, It's a stabbing sensation. It is an 8 out of 10 on the pain scale, and it gets worse when I walk. You have to advocate for your own biology.
And effective communication is the absolute bedrock of this shared decision-making model, which brings up essential legal rights regarding language.
Oh, this is a big one.
If English is not your first language, navigating complex medical jargon is incredibly dangerous. Under Title VI of the Civil Rights Act, any healthcare facility that receives federal funding, which is virtually every hospital in the country, is legally required to provide free professional interpreter services to patients with limited English proficiency.
The source is adamant about this. You should never, ever use your bilingual children as medical interpreters.
Never. First, it is deeply traumatic to ask a child to translate a cancer diagnosis for their parent. Second, medical translation requires precise terminology. A child or even a bilingual spouse might accidentally mistranslate angina or benign, leading to catastrophic medical errors. You have a federal right to a professional, neutral interpreter. Demand it.
And the text outlines several other crucial patient rights. You are a consumer with leverage. You have the right to informed consent, meaning a doctor cannot touch you without explaining the risks. You have the absolute right to completely refuse any treatment, even if the doctor disagrees. You have strict privacy protections under a law called IPO.
IPA is fascinating because it is so rigid. It means your medical information is entirely locked down. Even your legal spouse does not automatically get access to your medical records or your test results unless you have explicitly signed a waiver granting them permission.
You also have the right to demand a copy of your complete medical records and the right to file formal grievances if you are mistreated.
We also must briefly touch on mental health within this human element section. The text notes that finding mental health care in the U.S. is currently a profound struggle due to severe provider shortages nationwide.
Yeah, it's really tough right now.
Furthermore, many highly sought-after therapists and psychiatrists simply refuse to deal with insurance companies at all because the reimbursement rates are so low and the bureaucracy is so high.
Finding an in-network therapist is like finding a unicorn. If you want therapy, you often have to pay privately, out of pocket, which can cost anywhere from $100 to $300 a session.
It is a massive financial hurdle to mental wellness. However, the text does highlight a vital free resource, the 988 Lifeline. It is a 3-digit national number, available 24/7, connecting anyone in a mental health crisis directly with trained counselors.
It is an essential safety net. But if we're talking about the human element and the psychological toll of this system, we have to talk about the mailbox. Because the most distinctly American cultural dynamic mentioned in the entire text is what happens when the mail arrives after a hospital visit.
Oh boy, yes. The art of negotiation.
Because you will inevitably receive a document in the mail called an EOB, an explanation of benefits. Let's paint a picture of this because it induces pure panic. It arrives in a standard envelope. You open it, and it's a grid filled with jargon.
It shows a column for the amount billed, say $20,000. Then an allowed amount, then not covered. And down at the bottom, there's a terrifying number. But the text practically screams at the reader, the EOB is not a bill.
Right. Do not panic and absolutely do not write a check based on an EOB. An EOB is simply a communication receipt between the hospital and your insurance company.
It shows what the provider is asking the insurance to pay and what the insurance is aggressively refusing to pay. It is a snapshot of an ongoing financial argument. You must wait until the actual physical hospital sends you a formal invoice on their own letterhead. And even then...
Wait, this is the part of the text that absolutely blew my mind. You get the actual bill from the hospital, but the text says you shouldn't just pay that either. You can literally haggle over a hospital bill like you are buying a rug at a flea market.
What's fascinating here is that, yes, essentially you can and you should. To understand why, you have to understand the charge master.
What's a charge master?
The charge master is a hospital's internal master price list, and the prices on it are artificially, absurdly inflated. They set the price of a single Tylenol at $30 because they know the insurance company is going to negotiate them down by 80%. It is an opening bid.
Wow.
But if you are uninsured or out of network, you accidentally get hit with that full inflated charge master sticker price.
So the bill you get is literally just a starting anchor for a negotiation.
Exactly. And the source outlines a very specific step-by-step playbook for how to fight back. Step 1. When you get the bill, you call the hospital's billing department and you demand an itemized bill.
Because the original bill just says laboratory services, $4,000. Yeah. You want the itemized bill because it breaks down every single Band-Aid and aspirin.
Right. And hospitals frequently make massive administrative errors. They will double charge you for a room you weren't in, or charge you for medications you never took. Seeing every line item allows you to dispute the errors and immediately lower the total.
Step 2. If the bill is accurate but you cannot afford it, you ask for an application for charity care or financial hardship programs.
Yes. By law, nonprofit hospitals, which make up a huge percentage of U.S. hospitals, are legally required to offer sliding scale discounts or total debt forgiveness to middle and lower income patients.
But they'll never, ever volunteer this information.
Yeah, never. You have to explicitly ask for the application.
Step 3, the lump sum negotiation. If you have some cash saved but not enough to cover the whole bill, you call the billing manager. The text says you literally say, I cannot afford a $5,000 bill, but I have $3,000 in my checking account right now. If I pay you $3,000 today, will you consider the debt fully settled and clear my account?
And shockingly often, they will say yes. You can negotiate a 20 to 40% discount just by offering immediate guaranteed cash. The hospital would rather take a guaranteed partial payment today than spend years chasing you for the full amount.
And if that fails, step 4 is to set up a payment plan. You tell them you can only afford $50 a month. Hospitals will almost always agree to interest-free payment plans.
Because, again, they would much rather get $50 a month for the next 5 years than sell your debt to a ruthless collection agency for pennies on the dollar.
The one thing you must never, ever do is ignore the bills. Throwing them in the trash is the worst possible strategy.
Definitely. If a medical bill goes unpaid for too long, the hospital will send it to a collections agency. This will devastate your credit score. And in America, your credit score dictates everything. Your ability to rent an apartment, secure a mortgage, buy a car, or even get hired for certain jobs.
But the text makes one final crucial distinction to ease the anxiety. As destructive as ruined credit is, you cannot go to jail for medical debt. There are no debtors' prisons in the United States. It is entirely a civil contract dispute, not a criminal issue.
But navigating all of this, the relentless negotiations, the gatekeeping PCPs, the out-of-network traps, it takes an immense psychological toll.
Oh, absolutely.
It is exhausting for native-born citizens, let alone immigrants and newcomers translating the jargon. This is why the source explicitly advises building a strong community support network, and it specifically points to FQHCs.
Federally qualified health centers.
Right. These are community-based clinics funded by the government. They provide comprehensive primary and preventive care on a sliding fee scale based entirely on your income, and they treat everyone, regardless of their insurance status or their immigration status.
Oh.
They are essential safe havens in a highly turbulent, profit-driven system.
So what does this all mean? If we step back and synthesize everything we've unpacked in this deep dive, the core message is unmistakable.
Yeah, it really is.
The United States healthcare system is radically decentralized. It is not a passive safety net that catches you when you fall. It is a complex, hyper-financialized ecosystem that places the burden of navigation entirely, squarely on the shoulders of the consumer. You are required to be the aggressive project manager of your own health.
It is a system that actively punishes passivity. Conversely, it heavily rewards those who are proactive, meticulously organized, fiercely inquisitive, and unapologetically vocal.
So as you go out into this system, let's leave you with some final rapid-fire practical reminders to keep in your back pocket. Number 1, do not skip your free preventive care. Under the rules of the ACA, things like annual physicals, mammograms, and standard vaccines are legally required to be covered at 100% with absolutely no copays or deductibles. Use them to catch things early.
Good advice.
Number 2, always ask your doctor for generic medications and check the GoodRx app before you hand over your credit card at the pharmacy counter.
Number 3, remember that EMTALA is your ultimate safety net. It legally protects your life in an emergency room, regardless of the size of your wallet or the passport you hold.
And finally, number 4, being your own vocal advocate, asking questions, demanding itemized bills, challenging out-of-network ambushes is not just an option in America. It is a fundamental requirement for survival.
Which brings me to a final thought I want to leave you with, something for you to mull over that builds on the realities we've uncovered today.
I love these. Go for it.
If navigating the current U.S. healthcare system already requires a patient to simultaneously possess the combined skills of a Wall Street financial analyst, a legal contract advocate, and a medical translator, what does this mean for the future of human health equity?
Oh, wow.
As medical technology, genomic treatments, and highly personalized medicine become exponentially more complex and expensive in the coming decades, will the gap between those who know how to play the system and those who don't become the ultimate defining determinant of the human lifespan?
That is a chilling, but absolutely necessary question to consider as we look toward the future of medicine. It really brings us right back to that video game analogy.
It really does.
The rules of the board are endlessly complicated, occasionally unfair, and constantly shifting. But intimately knowing those rules is the only way to keep your piece on the board. Take these nuggets of knowledge, stay curious, advocate for yourself, and keep diving deep. We will catch you on the next one. Imagine walking onto a car lot to buy a brand new vehicle.
Okay.
But there's a massive catch. You are completely blindfolded.
That sounds like a terrible idea.
Right. The salesperson refuses to show you the sticker price, and get this, you aren't allowed to know what your monthly payments will be until you've already driven the car off the lot and used it for an entire month.
Yeah, nobody would ever agree to that.
No one. If that sounds like an insane, unacceptable way to conduct a financial transaction, well, welcome to the American healthcare system.
It really is a staggering reality, I mean, when you put it like that. We demand upfront pricing for like a $5 cup of coffee.
Exactly.
But we routinely sign these open-ended financial agreements for medical procedures that cost, more than a house.
And that is exactly why we are here today. Looking at this massive stack of sources you sent us, the articles, the research papers, the deeply personal notes, our mission for this deep dive into the source material is very clear.
We are building a survival manual.
Yes, the ultimate practical survival manual for navigating the really complex, messy, real-world scenarios of the United States healthcare system. Our goal is to transform you, the listener, from just a passive patient into an empowered, highly strategic project manager of your own healthcare.
I am so glad you used the phrase project manager because, well, we need to establish a foundational truth right out of the gate here.
Lay it on us.
The U.S. healthcare system is completely unique on the global stage. It heavily intertwines your actual biological medical care with complex financial structures, intense bureaucratic administration, and your employment status.
It's all connected.
Right. When you interact with the system, you aren't just managing a biological condition. You are literally managing a financial and administrative portfolio.
So whether you are, planning to start a family, managing a chronic illness, or just trying to prepare for the unexpected so a random Tuesday car accident doesn't bankrupt you, the tactical knowledge we are extracting from your sources today could literally save you thousands of dollars.
Absolutely.
But before we get into the advanced survival tactics, we have to make sure we are speaking the same language. We really need to define the financial building blocks because I see so many people completely misunderstand how their money actually flows through this system.
It is the biggest barrier to entry, honestly. People tend to gloss over the terminology because it feels like reading a tax code, right?
Oh, for sure. It's so dry.
But these definitions are the rules of the game. Let's start with the premium.
Okay, so I always think of the premium as like a subscription fee. It's the fixed amount you pay every single month just to have the insurance card in your wallet, regardless of whether you go to the doctor 0 times or 50 times.
That is a perfect analogy, but having the card doesn't mean your medical care is actually free.
Unfortunately.
Right. That brings us to the deductible. And this is the amount of money you must pay entirely out of your own pocket for covered medical services before your insurance company starts paying anything.
So if I have, say, a $2,000 deductible and I get a $5,000 hospital bill in January, I have to pay the first $2,000 myself.
Exactly.
The insurance company essentially just ignores me until I cross that threshold. It's like a cover charge to get into a club before you can even start ordering drinks.
That cover charge can be a massive hurdle for people. Now, once you finally meet that deductible, you still aren't off the hook.
Of course not.
You enter the phase of copays and coinsurance. A copay is a flat, fixed fee for a specific service. You pay $25 to see a specialist or maybe $15 for a generic prescription. It is very predictable.
But coinsurance is where the math gets really dangerous, right? Because it's a percentage, not a flat fee.
Yes. Coinsurance means you and the insurance company are splitting the bill.
Like an 80-20 split.
Yeah, that's a common one. The insurance pays 80% and you pay 20%. So if your hospital bill after meeting your deductible is $100,000, your 20% coinsurance leaves you with a $20,000 bill.
Wow. Which brings us to the only saving grace in this entire financial structure, which is the out-of-pocket maximum.
Safety net.
Right.
Yeah.
This is the absolute legal cap on what you have to pay in a single calendar year for in-network care. Once you hit this number through your deductibles, co-pays, and co-insurance, the insurance company steps in and pays 100% of the remaining costs for the rest of the year.
It is your ultimate financial safety net. But notice I specifically said in-network.
Ah, yes. The network trap.
If you step outside of your insurance company's approved network of doctors and facilities, that safety net completely vanishes, and you could be responsible for the entire bill.
Okay, so now that we have the vocabulary down, let's apply it to the real world. I want to start with the predictable shocks. The two most common, yet financially jarring, ongoing interactions a person can have with the medical system. Let's look at bringing a new life into the world. Having a baby in America.
This is a profound life event, obviously, but as your sources highlight, it is also a massive financial acquisition.
It really is.
The raw numbers frequently induce literal sticker shock, particularly for people who have immigrated to the U.S. from countries with universal health care.
Break down the actual math for us. What does it actually cost to have a child?
So for an uncomplicated standard vaginal delivery, the average cost when you bundle prenatal care, the delivery itself, and postnatal care, it ranges from $18,000 to $30,000.
Just for a routine birth where everything goes perfectly? That's wild.
And if a cesarean section is required, the cost jumps dramatically. You are looking at $25,000 to $50,000, and sometimes significantly more, depending on the regional cost of living and the specific hospital.
But those are the numbers before insurance, right? I mean, no one is actually writing a check for $50,000 to the maternity ward.
Usually not, no. But the post-insurance reality is still pretty severe. Even with robust employer-sponsored health insurance, the average out-of-pocket responsibility for the patient, factoring in those deductibles and co-insurance we just defined, it typically runs anywhere from $2,000 to $5,000 or more.
In countries like, Canada, the UK, Germany, or Scandinavia, maternity care essentially costs the patient nothing out of pocket.
Right. It's treated as a public good.
But here we have to treat it like a major corporate merger. You really need a strategy from day one. So based on the research, what is the blueprint for expectant parents?
It requires a highly proactive approach, starting the literal moment you see a positive test. Your first move is to pull your insurance policy documents and review the specific maternity coverage. Under the Affordable Care Act, maternity care is legally classified as an essential health benefit.
That sounds incredibly comforting. Essential means it's fully covered, right?
That is a very dangerous assumption.
Oh, no.
Yeah, all marketplace plans and most employer plans are required to offer coverage, but the word offer does a lot of heavy lifting there. The specifics vary wildly. Well, what percentage of the hospital stay do they actually cover? Does your plan have a separate deductible specifically for hospital admissions? What is your out-of-pocket maximum? You have to map out these numbers immediately to project your costs.
Oh, okay, so I read the fine print. But knowing my coverage doesn't really help if the hospital down the street doesn't take my insurance. How do I actually lock in the right facility?
This is the second vital move, and it is where many expectant parents fall into a massive financial trap. You need to choose an in-network OBGYN or an in-network certified nurse midwife. Most people know to do that.
Sure, that makes sense.
But the critical secondary part is verifying that the specific hospital or birthing center where that doctor has admitting privileges is also in-network.
Wait, let me make sure I'm following this. My doctor, who I see for 9 months in their private clinic, could be completely in-network.
Yes.
But the physical building they tell me to drive to when my water breaks might be out-of-network.
That happens with alarming frequency, actually. Doctors operate as independent contractors in many hospital systems, and if the facility itself is out of network, you will be hit with astronomical facility fees.
Explain facility fees, because this concept drives people crazy. What am I actually paying for if I'm already paying the doctor to be there?
You are paying for the room, you are paying for the electricity, the monitoring equipment, the nursing staff's time, the administrative overhead of the building itself. A facility fee can sometimes be larger than the doctor's actual fee for delivering the baby.
That is insane.
It is. You must aggressively verify that both the provider and the facility are in your network.
Which brings us back to the blindfolded car buying problem. I know the hospital is in network, but I still don't know the price. The sources suggest demanding a cost estimate. How realistic is that? Will a hospital actually tell you before you give birth?
Yes, and federal regulations regarding price transparency are increasingly forcing hospitals to provide these estimates. You can and absolutely should ask your insurance company for a pre-authorization and a detailed cost estimate for maternity care. It removes the blindfold.
And once you have that estimate, let's say they tell you it's going to be $3,500 out of pocket. This is when you need to leverage financial tools. Your notes mentioned the health savings account, or HSA. I feel like HSAs are wildly misunderstood by most people.
They really are.
People just think of them as regular savings accounts with a medical sticker slapped on them.
Yeah.
What makes an HSA so powerful?
An HSA is arguably the most powerful tax-advantaged account in the American financial system. It offers a triple tax advantage.
Triple. Okay, break that down.
First, the money you put into it goes in pre-tax, which lowers your taxable income for the year. Second, the money grows tax-free if you invest it. And third, when you withdraw the money to pay for a qualified medical expense, like your $3,500 maternity bill, that withdrawal is completely tax-free.
So you're essentially getting a massive discount on your medical bills just by funneling the money through this specific account.
Precisely. If you are eligible for an HSA, which usually requires having a high deductible health plan, funding it aggressively during pregnancy is a brilliant defensive maneuver.
But let's look at the actual clinical side of pregnancy, because the medical landscape has changed so much. When our parents had kids, prenatal care was like a few blood pressure checks and maybe one fuzzy ultrasound.
Right.
Now, there's a whole menu of specialized tests. How do we navigate paying for those?
Standard prenatal visits, routine blood work, and basic anatomical ultrasounds are usually seamlessly covered as preventative care. But modern obstetrics involves a lot of specialized testing, particularly genetic screenings for chromosomal abnormalities, like non-invasive prenatal testing or NIPT.
And insurance companies view those differently.
Very differently. Many insurers consider these specialized tests investigational or only medically necessary for pregnancies over the age of 35.
Oh, wow.
Yeah, so if you are 28 and your doctor casually suggests a genetic screening, your insurance might flat out refuse to cover the $1,000 lab fee. You have to develop the habit of asking before any blood is drawn. Is this standard or is this specialized? And has my insurance explicitly authorized it?
That is the project manager mindset in action right there. But let's look at the aftermath. The baby arrives, you survive the hospital stay, and you go home. Now we hit the reality of employment law, the Family and Medical Leave Act, FMLA.
This is a stark area of American exceptionalism. FMLA is a federal law enacted in 1993, and it entitles eligible employees to take up to 12 weeks of job-protected leave for the birth or adoption of a child.
And job-protected just means they can't fire you and give your desk to someone else while you are recovering.
Right.
But the operative word that the sources highlight is unpaid.
The federal law guarantees $0 in compensation. The United States stands alone among developed, industrialized nations in not mandating paid maternity or paternity leave at the national level.
It's unbelievable.
Furthermore, FMLA only applies to companies with 50 or more employees within a 75-mile radius. If you work for a small business with 20 employees, federal law does not guarantee you a single day of leave, paid or unpaid.
Why 50 employees? That seems like an incredibly arbitrary cutoff for a basic human right like bonding with a newborn.
It was a political compromise. When the law was debated, business lobbying groups argued that forcing small businesses to hold positions open for 12 weeks would bankrupt them. So the 50-employee threshold was created to exempt small businesses from the administrative burden.
So if you're an expectant parent listening to this, you have to investigate your specific situation immediately. Some progressive employers offer paid leave as an added perk. And your notes show that a handful of states like California, New York, New Jersey, Washington, they have implemented state-level paid family leave programs funded through payroll taxes.
Yes, but it is far from a universal guarantee.
Right. And while you are navigating your leave, you are also racing against the most dangerous administrative trapdoor in early parenthood, which is the 30-day clock.
Oh, yes.
Let's unpack this because it sounds like a literal ticking time bomb.
It really is. When a child is born, they do not automatically permanently attach to your insurance plan. The birth is what the insurance industry categorizes as a qualifying life event.
Okay.
This classification grants you a strict, legally binding 30-day window from the exact date of birth to formally submit the paperwork, adding the newborn to your health insurance policy.
And if you are exhausted, recovering from major abdominal surgery, sleep deprived, and you finally get around to calling HR on day 31, what actually happens?
The window slams shut. You will likely be locked out, and you will not be able to add your child to your insurance until your company's next annual open enrollment period, which could be 10 months away.
Wait, really?
Yes. Your infant will be entirely uninsured for all of their crucial early pediatric visits, vaccinations, and any potential medical emergencies.
That is absolutely terrifying. You literally need to set an alarm on your phone from the delivery room. Do not miss that window. Okay, we've covered bringing a life into this system. Let's pivot to the other massive ongoing interaction, managing a chronic condition. Because an acute injury, like a broken arm, is an event. But a chronic condition is a lifestyle.
And it is a lifestyle shared by the majority of the country. We are discussing diabetes, hypertension, asthma, autoimmune disorders, heart disease. Approximately 60% of American adults are living with at least one chronic condition.
60%.
Yeah. If you are in this demographic, your relationship with the healthcare system is not an occasional inconvenience. It is a permanent, heavily administrative, and very expensive reality.
This completely upends how you should approach open enrollment every November. I mean, if I am healthy, I might just pick the cheapest plan. But if I have a chronic condition, how does that change the fundamental math of choosing an insurance plan?
It changes everything, particularly regarding high-deductible health plans. HDHPs are heavily marketed during open enrollment because they feature very low monthly premiums. They look like a great deal on paper.
Right, I see those premiums and think, great, I'll save $200 a month. Why is that a trap for someone with diabetes or rheumatoid arthritis?
Because we have to calculate utilization. If you have a chronic condition, you are a high utilization patient. You are visiting a primary care physician regularly. You are seeing specialists like an endocrinologist, a rheumatologist, a cardiologist.
Right.
You require quarterly lab panels. You are filling expensive prescriptions every single month.
So I am interacting with the serum constantly right from January 1st.
Exactly. And because of that constant interaction, you are going to blow through your deductible very quickly. If you choose an HDHP with a $5,000 deductible, you might be on the hook for that entire $5,000 out of pocket within the first 3 months of the year before the insurance coverage really activates.
Ouch.
It creates a massive cash flow crisis for families.
I see. So what is the alternative strategy?
For chronic care, it is often mathematically superior to choose an HMO or a PPO plan with a much higher monthly premium, but a significantly lower deductible. You are essentially trading a higher predictable monthly cost for protection against massive, sudden out-of-pocket spikes. You want your insurance company to start paying their share, the co-insurance, as early in the calendar year as possible.
That makes perfect sense structurally.
Yeah.
But let's look at the reality of medication costs, because your sources highlight a disparity that is truly shocking. Let's talk about diabetes management.
Okay.
Metformin is an older, widely used generic drug. It costs maybe $10 to $30 a month. But then you have a newer class of drugs, the GLP-1 receptor agonists.
Drugs like Ozempic, Wegovy, or Mounjaro.
Yeah.
If your insurance decides not to cover them, or if you are still paying down a high deductible, the retail cash price for these medications can easily range from $800 to $1,500 per month.
That is a mortgage payment for one medication that is completely unsustainable for almost anyone. How do patients actually survive that kind of pricing? What are the tactical workarounds here?
You have to employ a multi-layered medication management strategy. Strategy number 1 is the golden rule of pharmacy. Always explicitly ask your doctor and your pharmacist for generic alternatives. If a generic exists, it is chemically identical to the brand name by law, and it costs a fraction of the price.
But with these newer biologic drugs, or GLP-1s, the patents haven't expired yet. There are no generics. So what is strategy 2?
Strategy 2 is mastering your insurance plan's preferred drug formulary.
What is a formulary, practically speaking?
A formulary is simply a tiered list of prescription drugs covered by your specific health plan. Insurance companies negotiate secret rebate deals with pharmaceutical manufacturers.
Of course they do.
Because of these deals, your insurance might refuse to pay for brand X, but they will happily cover brand Y for a $30 copay, even though both drugs treat the exact same condition.
So if my doctor prescribes brand X and the pharmacist tells me it's $1,000, I don't just walk away and give up. I have to go back to my doctor. What is the exact phrasing I should use?
You tell your doctor, my insurance formulary does not cover this drug. Can you prescribe a therapeutic alternative in the exact same class that is on my preferred tier?
Therapeutic alternative.
Yes.
Yeah.
That phrase signals to the doctor that you need a drug that achieves the same clinical outcome, but aligns with your specific corporate insurance contracts.
And what if there is no alternative? What if you absolutely need a specific brand name drug?
Then you bypass the insurance company entirely and go directly to the source. Strategy 3 is utilizing manufacturer patient assistance programs and copay cards.
How does that work?
Pharmaceutical companies know their list prices are absurd. They often provide discount cards directly on their websites that can reduce an $800 monthly copay down to $25.
Wait, why would a pharmaceutical company voluntarily slash their own price for me? That feels philanthropic, which I know it isn't.
It is entirely strategic. They offer you a $25 copay card to keep you physically taking their drug and loyal to their brand, while they spend months negotiating aggressively with your insurance company behind the scenes to eventually force the insurer to cover the bulk of the cost. You are leveraging their corporate warfare to your own advantage.
Speaking of warfare, the cost of insulin has been a battlefield for decades. People rationing insulin because they can't afford it. Has there been any actual progress there?
There has been substantial legislative movement, yes. Strategy 4 is leveraging the Inflation Reduction Act of 2022. This legislation implemented a hard cap on the out-of-pocket cost of insulin, restricting it to $35 per month for patients enrolled in Medicare.
That's just Medicare. What about everyone else?
The federal law only mandated it for Medicare, but the public pressure it generated caused a massive ripple effect. Several major insulin manufacturers voluntarily capped out-of-pocket costs at $35 for many private insurance patients as well, and several states have passed their own laws mandating similar caps.
That's huge.
It is. If you require insulin, you must investigate whether your specific state or your specific manufacturer has implemented these cost reductions.
So if you have a chronic illness, you are tracking formularies, hunting down manufacturer copay cards, negotiating alternative prescriptions with doctors, monitoring legislative price caps. This isn't just taking a pill. This is literally a part-time job.
It is a massive cognitive and administrative burden, which brings us to the final necessity for chronic care survival. You must centralize your administration by aggressively utilizing patient portals.
You mean the apps or websites like MyChart that the hospital systems constantly prompt you to download?
Yes. You cannot manage a complex chronic condition in the modern American system using paper files, voicemails, and Post-it notes. It is too precarious.
I can imagine.
You need to use these centralized online platforms to view test results the moment they are available, send direct messages to your care team to clarify instructions, track your historical lab trends, and request prescription refills with a single click. It is really the only way to maintain your sanity and ensure all your various specialists are looking at the same data.
You're managing stakeholder alignment, basically, getting the endocrinologist to talk to the primary care doctor.
Exactly.
We've covered the predictable milestones, birth, and chronic management. But your sources detail a much darker reality we need to explore next. Managing your health is hard enough when things are stable, but in the United States, your access to healthcare is heavily tethered to your employment.
It is a profound systemic vulnerability. Your biological well-being is intrinsically linked to your economic utility to an employer.
So what happens when that tether snaps? What happens when you lose your job? Or even more complicated, what happens when your job is the actual physical cause of your medical emergency? Let's walk this bureaucratic tightrope, starting with job loss.
When you lose your job in America, you endure a dual trauma. You lose your primary source of income, and simultaneously, you often lose your ability to pay for medical care. The two are linked in a way that is virtually unheard of in other highly developed nations.
But whenever layoffs happen, you always hear people casually say, oh, don't worry, you could just go on COBRA. It's spoken about like it's this warm, comfortable safety net waiting to catch you.
COBRA is one of the greatest illusions in American healthcare.
Really? Let's break down the mechanics then.
COBRA stands for the Consolidated Omnibus Budget Reconciliation Act. It is a federal law enacted in the 1980s that grants you the right to temporarily continue the exact same employer-sponsored health insurance plan you had while you were working, usually for up to 18 months after termination.
Okay, that sounds fantastic. I keep my same doctors, my same network. What is the catch?
The catch is mathematically brutal. When you were employed, you were likely only paying a fraction of your insurance premium. Most large employers subsidize a massive portion, usually 60 to 80% of the total monthly cost as part of your compensation package.
Right.
You only saw your smaller portion deducted from your paycheck.
So I was paying, say, $150 a month, and the company was secretly paying $600 behind the scenes.
Exactly. Under COBRA, the employer's subsidy completely evaporates. You are now legally responsible for 100% of the premium, plus the law allows the administrator to charge an additional 2% administrative fee.
Wait, so I have to pay 102% of the actual retail cost of the insurance?
Yes. The plan that cost you $150 a month out of your paycheck might suddenly cost you $800 or well over $2,000 a month for family coverage under COBRA.
That is insane.
At the exact moment you have lost your salary, your healthcare costs quadruple. COBRA is a short-term bridge for the wealthy, or for people in the middle of a complex medical treatment who simply cannot risk changing doctors. It is not a sustainable long-term solution for the average person.
If COBRA is financially impossible for someone who just got laid off, what are the actual viable alternatives?
The primary alternative is the health insurance marketplace, created by the Affordable Care Act. Losing your employer-sponsored insurance is legally classified as a qualifying life event.
Ah, there's that phrase again, just like having a baby.
Yes. It triggers a 60-day special enrollment window. You do not have to wait for the traditional end-of-year open enrollment period. You can sign up for a marketplace plan immediately.
But are marketplace plans actually affordable if I don't have an income?
They can be highly affordable because the marketplace utilizes a sliding scale of income-based subsidies, often delivered as advanced premium tax credits. Because you just lost your job, your projected annual income is suddenly much lower. This means you might qualify for significant federal subsidies that dramatically reduce your monthly premium, sometimes down to $0.
That's amazing. What if my income drops so low that I can't even afford a subsidized plan?
Then you transition to alternative 2. Medicaid. Medicaid is a joint federal and state program designed for individuals with very low income. If your current monthly income drops below a certain threshold, and remember, under the ACA, most states expanded Medicaid to cover all low-income adults, not just pregnant women or those with disabilities, you may qualify for free comprehensive coverage.
What if I have a spouse who's still working?
That is alternative 3. Your job loss is a qualifying life event for their employer's plan as well. Your spouse can contact their HR department and add you to their family insurance plan outside of their normal enrollment period.
Okay, I want to ask about something I see all over the internet. When you search for unemployed health insurance, you get bombarded with ads for short-term health insurance. The premiums look incredibly cheap, like $50 a month. Is that a smart hack if I just need coverage for 3 months while I interview for new jobs?
I cannot emphasize this enough based on the extensive warnings in your sources.
Oh.
Short-term insurance plans should be viewed with extreme skepticism and really only used as an absolute last resort.
Why? If it's cheap and gives me an insurance card, isn't that enough?
They are cheap because they are legally exempt from the consumer protection rules of the Affordable Care Act. They are essentially selling you a Swiss cheese safety net.
Oh, I see.
Short-term plans frequently refuse to cover pre-existing conditions. They rarely cover prescription medications. They do not have to cover maternity care or mental health services. And they can impose arbitrary, strict dollar limits on your care. If you buy a short-term plan and then get diagnosed with cancer, you might find the policy is virtually worthless when you actually try to use it.
It's just the illusion of coverage. So what is the overarching lesson here? What is the golden rule of navigating employment transitions in the American system?
The golden rule is never go uninsured, not even for a single month.
Never.
The systemic risk is simply too catastrophic. A sudden burst appendix, an accident on a bicycle, a slip and fall down the stairs, any of these routine human accidents can generate a 6-figure medical bill that leads to permanent financial ruin or bankruptcy. You must secure a bridge, whether it's the marketplace, Medicaid, or a partner's plan, the exact moment you lose your job.
Okay, that covers losing your job. But what if your job is actually the thing that physically harms you? Let's delve into workers' compensation.
Workers' compensation, commonly called workers' comp, is an entirely separate legal and medical universe from standard health insurance. It is a state-mandated insurance program that almost all employers are legally required to carry.
How does it actually work? What is the core philosophy behind it?
Historically, it was designed as a grand bargain between labor and management. Workers gave up their right to sue their employers for negligence after an injury. In exchange, the workers' comp system guarantees that if you are injured on the job or develop an illness as a direct result of your work environment, the system will cover 100% of your medical costs and provide a portion of your lost wages while you recover, regardless of who was at fault for the accident.
Give me some real-world examples. Were we just talking about dramatic factory accidents?
No, it absolutely covers acute trauma, like a delivery driver injured in a collision while on their route, or a warehouse worker breaking a leg falling off a ladder. But crucially, it also covers repetitive strain injuries and occupational diseases that develop slowly over time.
Like what?
If you are an office worker who develops severe, debilitating carpal tunnel syndrome from years of mandatory data entry, or a construction worker who develops chronic respiratory issues from long-term exposure to hazardous job site dust, you are covered.
How does a workers' comp claim interact with my regular Blue Cross or Aetna health insurance? Do I just hand the ER my normal insurance card if I get hurt at work?
No. This is a critical error many people make. Your personal health insurance should never be billed for a workplace injury.
Really?
They are completely separate pools of money. If you tell your personal insurance company that the injury happened at work, they will deny the claim and demand that workers' comp pay for it. Under an approved workers' comp claim, you do not pay any copays, and there are no deductibles. The medical care is fully covered.
I want to highlight a truly vital legal reality from our sources, specifically regarding vulnerable labor populations. What happens if a worker is undocumented? Are they just out of luck if their hand gets crushed in a commercial kitchen or on a farm?
This is a profound point of law that is frequently misunderstood. Regardless of immigration status, all workers in the United States are entitled to workers' compensation rights.
Even if they aren't legally authorized to work in the country?
Yes. The legal rationale focuses on the labor performed, not the immigration status. If undocumented workers were excluded from workers' comp, it would actually incentivize exploitative employers to hire undocumented labor for the most dangerous, hazardous jobs, knowing they would face zero financial consequences if those workers were maimed or killed. The law protects the worker to regulate the employer.
Wow, that makes a lot of sense. So if you are undocumented and you get hurt, your employer's workers' comp insurance must cover your medical bills. But I imagine some employers, especially those operating in gray areas, might try to convince an injured worker to stay quiet.
They absolutely do. Employers will sometimes offer to just pay cash out of pocket, or they will threaten the worker with retaliation or deportation, or they will tell the worker to just go to the emergency room and lie, claiming it happened at home. All of these actions by the employer are entirely illegal.
So what is the exact step-by-step action plan if you suffer an injury at work?
Step 1. Report the injury to your manager or HR department immediately, and do it in writing. An email, a text message, or a formal incident report creates an undeniable paper trail with a timestamp.
Got it. Step 2.
Step 2. Seek approved medical treatment. Now, this varies by state. In some states, your employer has the legal right to direct you to a specific company doctor or occupational health clinic for the initial evaluation. In other states, you have the right to choose your own treating physician immediately. You must ask HR what the state requirement is.
And step 3 is filing the actual claim.
Yes, formally filing the workers' comp claim through your state's workers' compensation board. Your employer is legally obligated to provide you with the necessary forms within days of the injury.
What if they fight back? What if you file a claim for a severe back injury and the employer's insurance company denies it, claiming you probably just injured your back playing softball over the weekend?
Denials are incredibly common. The insurance companies are aggressively trying to limit their financial liability. If your claim is denied, you do not give up. You have the legal right to appeal before an administrative law judge, and this is the moment you must seek out a specialized workers' compensation attorney.
But if I'm injured and not getting a paycheck, how can I afford a specialized lawyer? They'd charge hundreds of dollars an hour.
You don't pay them hourly. The vast majority of workers' comp attorneys operate on a contingency fee basis.
Meaning they only get paid if I win.
Exactly. A contingency basis means the attorney takes the case for $0 upfront. They only receive a payment, usually a state-capped percentage, like 15 or 20% of your final financial settlement or retroactive wage award, if they successfully win the case. If the judge rules against you, you owe the attorney nothing for their time. It is a system designed to allow injured, cash-strapped workers to access top-tier legal firepower against massive insurance corporations.
All right, we have our insurance locked down, we've survived the employment tightrope, and we know our legal rights. Now we have to actually use this insurance inside a room with medical professionals. We are heading to the front lines, strategic communication and the clinical encounter.
This is where all your administrative preparation collides with human reality. The American medical system is rushed, overworked, and highly compartmentalized. If you don't know how to command the exam room, you will easily fall through the cracks.
Let's start before we even set foot in the clinic. Mastering the doctor's appointment begins with the phone call to the scheduler. The sources provided an incredibly specific script for this initial call, and I want to analyze why it's so effective.
Sure.
When you call, you shouldn't just say, "Hi, I need to see a doctor because my stomach hurts." You're supposed to state clearly if you're a new or established patient, immediately identify your exact insurance network, and ask precisely what medical records you need to bring. Why so specific?
Because the front desk administrators are the triage masters of the clinic schedule. If you say, "I have an Aetna PPO, I am a new patient, and I need a gastrointestinal consult," they can instantly calculate several things. First, new patients require a 45-minute scheduling block, whereas established patients might only need 15 minutes.
That makes sense.
Second, by stating your exact insurance up front, they can instantly verify if the doctor actually accepts your network before you waste 3 weeks waiting for an appointment only to be turned away at the door.
And asking what records to bring.
That ensures continuity of care. If you show up empty-handed, the doctor has to spend the first 20 minutes of your expensive appointment asking you to blindly remember what year you had a specific surgery or what your last lab results were. If you ask in advance, you can ensure they have your chart, allowing the doctor to actually diagnose you rather than just interview you.
Okay, so you get the appointment. You are sitting on the crinkly paper on the exam table. The doctor walks in, opens their laptop, and asks the classic question, "What brings you in today?"
I think the natural human instinct is to be casual and say something like, "Yeah, my back has just been killing me lately," or "I've been feeling really exhausted."
And from a clinical diagnostic perspective, vague language like that is practically useless.
Why? I mean, I'm telling them what hurts.
Because "my back hurts" describes 1,000 entirely different pathological conditions. It could be a simple pulled muscle from lifting a box. It could be a herniated disc compressing a spinal nerve. It could be a severe kidney infection. It could even be referred pain from an aortic aneurysm.
Oh, wow.
Yeah. Patients must train themselves to use specific, structured, clinical descriptors.
Break down that structure. How should I describe the pain?
First, you utilize the 1 to 10 pain scale to establish severity objectively. Second, you must differentiate the quality of the pain. Is it a dull, diffuse ache, or is it a sharp, localized stabbing sensation? Does it burn or does it throb? Okay, so instead of "my back hurts," I say, "I have a sharp, stabbing pain in my lower right back, and it's a 6 out of 10.
Much better. But we need to add duration and triggering factors. The complete project manager response sounds like this. "I have had a sharp, stabbing pain in my lower right back for exactly 3 weeks. It sits at a 4 out of 10 normally, but it spikes to an 8 out of 10 specifically when I bend forward to tie my shoes or when I sit in my office chair for more than an hour. Lying flat on the floor and taking 400 milligrams of ibuprofen relieves it slightly."
That paints an incredibly vivid, precise picture.
You are essentially handing the doctor the diagnostic puzzle pieces already sorted by color and shape. You allow them to bypass 20 basic filtering questions and immediately begin formulating a precise differential diagnosis.
This brings up a concept I love from the sources, the proactive patient. I compare this to interviewing a general contractor to renovate your kitchen. When a contractor walks into your house and says, "We're going to tear down this wall and run new plumbing," you don't just blindly nod and hand them a blank check.
Right.
You ask questions. You ask if they need to pull city permits. You ask about the timeline. You ask what materials they're using. We need to treat medical recommendations with that exact same level of inquisitive scrutiny.
That is a phenomenal analogy. When a doctor says, "I'm going to order an MRI for your back and send you to physical therapy," a passive patient just says, "Okay, sounds good." A proactive patient asks the permit questions.
What are the specific permit questions we should be asking in the exam room?
Question 1 regarding the MRI. Will this imaging require a prior authorization from my insurance company? You need to know if you are waiting on a bureaucratic approval process before you fruitlessly try to call the imaging center to schedule the scan.
Which leads to question 2 about the location.
Yes. Is the specific imaging center you are referring me to in my insurance network? We discussed this with maternity care. The doctor's clinic might be in-network, but the MRI facility they own across the street might not be. You must verify.
And what about the physical therapy?
Question 3. How many physical therapy sessions does a typical insurance plan cover for this specific diagnosis code? You need to understand your scope of work. Are you authorized for 5 sessions to learn some stretches? or 50 sessions for intense rehabilitation?
Right.
And finally, the most practical clinical question for your daily life. What physical activities should I completely avoid doing in the meantime so I don't exacerbate the injury before the MRI?
By asking these questions, the dynamic in the room shifts completely. You are no longer just a subject receiving top-down instructions. You are an active partner in formulating the treatment plan. But what happens if you fundamentally disagree with that plan? What if you feel like the doctor is missing something crucial, rushing you, or outright brushing off your symptoms?
This requires perhaps the most delicate yet vital skill in modern medicine: the art of disagreeing with a doctor. You have to learn how to respectfully but firmly advocate for your own body, and we cannot ignore the systemic realities highlighted in the research. There is voluminous peer-reviewed data demonstrating that women, and particularly people of color, routinely have their pain minimized and their symptoms dismissed by medical professionals due to implicit bias.
So how do you push back in that moment? If you were sitting there in a paper gown feeling vulnerable, how do you challenge a medical authority without seeming hostile or combative?
It is entirely about phrasing. If a doctor dismisses your severe fatigue and joint pain as probably just stress or part of getting older, and you intuitively know something is biologically wrong, you can use a powerful framing question. Can you walk me through your clinical reasoning for that diagnosis? I want to make sure I fully understand why we are ruling out other possibilities.
That's brilliant. It's perfectly polite, it sounds collaborative, but it demands intellectual accountability.
Exactly. It forces the doctor to stop, verbally articulate their diagnostic thought process, and justify their conclusion. Frequently, the act of speaking it aloud makes them realize they skipped a logical step or failed to order a baseline test.
What if they double down and just say, I'm the doctor, it's just stress?
You escalate the phrasing. You ask, are there alternative diagnoses we should be considering here? Or, if they refuse to order a test you feel is necessary, you use the ultimate accountability phrase. I understand you don't feel the test is necessary, but I would like you to document in my medical chart that I specifically requested further testing for this symptom and it was denied.
Does that actually work?
It is incredibly effective. That phrase alone often causes a provider to instantly reconsider because it creates a permanent legal record of their refusal. If they are wrong and you later suffer a severe consequence, that documentation is a massive medical malpractice liability.
And if they still refuse to listen after all that?
Then you remember your ultimate power in the American healthcare marketplace. You are a paying consumer. You can always fire your doctor and seek a second opinion. You do not have to endure dismissive care.
Speaking of situations that feel dismissive or frustrating, we have to talk about the emergency room. Because the reality of how an ER operates is fundamentally misunderstood by the general public, leading to immense anger. Let's explore why waiting in the ER often takes 6, 8, or 10 hours.
The anger stems from a complete misunderstanding of the logistical model. People instinctively think the ER operates like a bakery counter or the DMV. You take a number and it's first come, first served. It is not. Emergency rooms operate on a strict, ruthless clinical triage system.
Triage meaning sorting patients by the severity of their condition.
Precisely. Triage dictates that medical severity dictates priority, entirely regardless of your arrival time. If you arrive at 2 p.m. with a deeply sprained ankle and a broken finger, you are in pain, but you are stable. If someone arrives at 4 p.m. clutching their chest, exhibiting symptoms of an active myocardial infarction, a heart attack, that patient is skipping the line and going straight into a resuscitation bay. If an ambulance arrives at 5 p.m. with a trauma patient from a high-speed car crash, they skip the line too.
So if I am sitting in the ER waiting room for 6 hours, furious that people who came in after me are being seen first, it actually means I am having a relatively good day, medically speaking. I am not actively dying.
That is the exact perspective you need. It is frustrating to wait in pain, but the delay means the system is working exactly as intended, allocating finite resources to save the most critical, immediate lives first.
But once you finally get back to a room, there is a massive hidden financial trap in the ER that I had never heard of until I read these sources. Specifically, if the doctor decides to keep you in a bed overnight, it involves the terms observation versus inpatient status. Explain this mechanic, because the financial implications are mind-blowing.
This is one of the most insidious, purely bureaucratic financial quirks in hospital billing. It primarily affects patients on Medicare, but it routinely impacts private insurance as well.
Okay, walk us through it.
Let's walk through this scenario. You go to the ER with severe abdominal pain. They run a CT scan, but the results are ambiguous. The ER doctor says, "We aren't sure what's wrong. We want to keep you overnight in a bed upstairs, run a few more tests in the morning, and keep a close eye on you."
That sounds completely reasonable. They wheel me upstairs. I am lying in a hospital bed.
Yeah.
I am eating terrible hospital food. I am wearing a hospital gown, and nurses are checking my vitals every 4 hours. By every logical definition, I have been admitted to the hospital.
Logically, yes. Legally and financially, no. You might be held under what the hospital and insurance companies classify as observation status. This means that technically, legally, for billing purposes, you are still an outpatient. You have never been formally admitted to the hospital as an inpatient, even though you slept in their bed for 2 days.
Wait, why does a semantic classification matter? A bed is a bed. The medical care is identical.
It matters because outpatient billing and inpatient billing pull from completely different pools of your insurance benefits. Under observation status, because you are technically an outpatient, you might be billed hourly for the use of the room. You might be charged individually for every single Tylenol pill they hand you. You are likely subject to your high outpatient deductibles and a 20% coinsurance on every single test they run.
And if I were formally admitted as an inpatient?
If the doctor officially ordered an inpatient admission, your entire stay would likely be bundled and covered under a single comprehensive hospital deductible or a flat, predictable copay for a hospital admission.
So, lying in the exact same physical bed, receiving the exact same medical care from the exact same nurses could cost me thousands of dollars more simply because a doctor clicked the observation box instead of the admission box in the computer system.
Yes. And the trap gets deeper for Medicare patients. Medicare has a very strict rule regarding skilled nursing facilities. If an elderly patient needs to go to a rehab facility after a hospital stay, say, to learn how to walk again after a fall, Medicare will only pay for that expensive rehab if the patient had a prior formal inpatient hospital stay of at least 3 consecutive days. This is known as the 2-midnight rule.
Wait, so if my grandmother is kept in the hospital for 4 days under observation status and then needs to go to a rehab facility,
Medicare will deny the rehab coverage entirely, claiming she never technically had a qualifying hospital stay. The family will be billed tens of thousands of dollars out of pocket for the nursing facility.
that is devastating. So as an empowered project manager, what is the action plan?
You, or your designated advocate, must proactively and repeatedly ask the nurse or the attending physician, am I formally admitted as an inpatient right now, or am I here under observation status?
And if they say observation,
You ask the doctor to clearly explain the clinical criteria preventing a formal admission. You advocate for an inpatient order if the medical complexity of your condition warrants it. You do not just passively accept the bed.
okay, let's assume the clinical encounter is finally over. You survived the ER, you got your diagnosis, you went home. But the financial encounter has just begun. We are transitioning from the hospital bed to the billing department. Welcome to the paperwork battlefield.
And this is where the system's biggest, most expensive flaws hide in plain sight.
Let's start with medical billing errors. I want to emphasize a statistic from the stack of sources that genuinely took my breath away. Up to 80% of medical bills contain errors.
80%. It is an astronomical failure rate.
How is a failure rate that high even statistically possible in a modern computerized industry? If 80% of grocery store receipts were wrong or 80% of credit card statements were mathematically incorrect, there would be congressional hearings and riots.
It is possible because medical billing is not just arithmetic. It is a uniquely complex, highly subjective translation language. Everything that happens to you in a hospital, every diagnosis, every swab, every minute of surgery, has to be translated into specific alphanumeric codes. There are over 70,000 different codes in the ICD-10 system alone. A human medical coder, or increasingly an imperfect automated AI system, has to read a doctor's rushed, handwritten chart notes and assign the exact right codes.
So it's a translation error.
It is entirely human error compounded by systemic complexity. A single typo hitting a 4 instead of a 5 on a keyboard can change the code for a routine $50 preventative blood test into the code for a highly specialized $2,000 surgical pathology screening. Add in the chaotic, constantly shifting contractual rules between the hospital and dozens of different insurance companies, and errors aren't just an anomaly, they are the mathematical norm.
So what is our strategy? How does an individual patient fight back against an 80% error rate generated by a massive bureaucracy?
You fight back by employing the EOB strategy. EOB stands for Explanation of Benefits. This is the document your insurance company mails to you or posts in your portal, after a medical claim is processed.
I think most people look at that piece of paper, see a bunch of numbers, see the words, "This is not a bill," stamped at the top, and just throw it in the recycling bin.
Which is exactly what the system relies on. The EOB is not a bill, but it is the master ledger. It shows exactly what the hospital charged, what the insurance company's privately negotiated discount rate was, what the insurance company actually paid, and crucially, the final line item, what your specific patient responsibility is based on your deductible and coinsurance.
Let's walk through a specific scenario to make this concrete for the listener. Show me the project manager in action.
Okay. You go in for an outpatient MRI on your knee. A few weeks later, you open your mail, and there is a bill directly from the hospital for $1,200. The natural conditioned response is to sigh, pull out your credit card, and pay it so it doesn't go to collections.
But the project manager stops. They put the credit card away.
Exactly. The project manager files the bill in a folder and waits for the EOB from their insurance company to arrive. When it does, they compare the two documents. The EOB shows that the hospital originally charged $3,200 for the MRI. But because the hospital is in network, the insurance company's contracted, negotiated rate is only $1,800.
Okay, tracking.
The insurance paid their 80% share of that $1,800. According to the math on the EOB, your specific 20% patient responsibility is only $450.
Wait. The hospital sent me a bill demanding $1,200, but my insurance company is telling me I only legally owe $450.
Yes. This is a classic everyday billing error. The hospital's accounting department likely failed to properly apply the insurance network's contractual adjustment to your specific account before generating the invoice.
If I had just blindly paid the $1,200 bill when it arrived, I would have overpaid by $750. And I assume the hospital isn't going to rush to send me a refund check.
You would likely never see that money again. So what are the actionable steps? Actionable step 1, never, ever pay a medical bill immediately upon receipt. Always wait for the EOB to verify the math.
That makes total sense.
Actionable step 2, call the hospital's billing department. You do not need to be angry, you just need to be precise. You reference the account number and say, I am looking at my insurance EOB, which indicates my patient responsibility is $450, but your invoice states $1,200. It appears the contractual network adjustment wasn't fully applied. Could you please review and reprocess this claim?
And usually the person on the phone looks at the screen, sees the discrepancy, and fixes it.
Often, yes, it is a routine correction for them. Now, actionable step 3. While you have them on the phone, if you were in the hospital for more than a simple scan, you must request an itemized statement. Do not accept a summarized bill that just says laboratory services, $8,000, or pharmacy, $4,000.
You want to see the receipts.
You want to see every single line item. An itemized statement lists every individual blood draw, every single Tylenol pill, every pair of surgical gloves charged to your room. When proactive patients review itemized bills, they frequently find charges for procedures that were canceled, medications they never actually received, or being double billed for the same doctor visiting the room twice in one day.
It's like checking out of a hotel and looking at the folio, only to discover they charged you $50 for raiding the minibar when you didn't even open the fridge. You have to audit the folio.
Precisely. And actionable step 4. Once the bill has been audited, corrected, and you agree that the $450 is accurate, what if you still can't afford to pay that lump sum right now? You ask the billing department for an interest-free payment plan. Most hospital systems, especially nonprofits, will readily allow you to break the bill into manageable monthly installments over 12, 24, or even 36 months without charging you a single cent of interest. You just have to explicitly ask for the hardship plan.
Okay, that covers fighting the hospital's accounting mistakes. But what happens when the hospital did everything right, but the insurance company itself is the one attacking you? Let's talk about the appeals process. What is the reality of fighting an insurance denial?
This is perhaps the most grueling reality of the American system. You consult with your doctor determines you urgently need a specific surgery or a biologic medication. They submit the prior authorization request to the insurance company. And 3 weeks later, you receive a letter declaring an adverse benefit determination.
Which is a very sterile, legalistic way of saying access denied, we won't pay for it.
Yes. And the most common, deeply infuriating phrase deployed in these denial letters is that the requested service was deemed not medically necessary.
I have to pause here and ask about the underlying logic. Your literal doctor, a human being who went to medical school for a decade,
Oh,
who physically examined your body, who knows your history, says you need this treatment to heal. Why does a distant clerk or a software program at a corporate insurance company possess the legal authority to overrule your doctor and declare it not medically necessary? Do they just deny things, hoping we will give up?
The cynical but statistically accurate answer is yes. The business model essentially relies on patient exhaustion. Insurance companies utilize highly complex proprietary algorithms and broad, generalized clinical guidelines to make initial coverage decisions. It's an automated, sweeping net designed to catch outliers and save money. The algorithm doesn't know the nuanced, specific reality of your biological suffering.
Right.
And the insurance executives know that the vast majority of patients who are already physically sick, tired, and overwhelmed will simply look at the denial letter, accept defeat, and either forgo the life-saving treatment or bankrupt themselves paying out of pocket.
It is literally a war of attrition. So how do we fight back? If the algorithm says no, we need a battle plan to force a human to say yes. Walk me through the strategy for an appeal.
Step 1, read the denial letter thoroughly and analytically. You have to know the exact reason for the denial to formulate a counterattack. Was it denied due to a simple administrative missing code? Or was it denied because they consider the procedure experimental rather than standard of care? You must know your enemy's logic.
Okay, I know why they denied it. Step 2.
Step 2, rally your clinical allies. Contact your doctor's office immediately. Inform them of the denial and ask the prescribing doctor to draft a letter of medical necessity.
But what exactly goes into that letter? Is it just the doctor saying, please pay for this?
No, it is a formal, heavily referenced clinical document. Your physician must cite peer-reviewed medical studies, clinical trial data, and your specific documented medical history to legally justify why you need this exact treatment and why cheaper alternatives have already failed or are contraindicated for your specific body. You should also request they include all relevant clinical chart notes to build an undeniable evidence file.
We have our evidence package. Step 3.
Step 3, file the formal written internal appeal with the insurance company. You submit the required forms, your doctor's letter of medical necessity, the chart notes, and a personal statement detailing how the condition impacts your daily life and why the denial is erroneous.
And step 4 is about the clock, right? The system loves a deadline.
Step 4 is absolutely vital. You must execute this within the strict legal deadline. Insurance companies grant you a very specific, unforgiving window to file an appeal, usually between 30 and 180 days from the date stamped on the denial letter. If you gather all the perfect evidence but submit the appeal on day 181, your case is automatically dismissed on procedural grounds, regardless of how desperately you need the medical care. They will use any procedural excuse to close the file.
Let's play out the worst-case scenario. We do everything right. We submit the letter of medical necessity on time. The insurance company conducts an internal review, they investigate it themselves, and surprise, surprise, they uphold their own denial. They say, nope, we still won't pay. Are we out of options?
No. That brings us to your ultimate weapon, step 5. Demand an external, independent third-party review. If your internal appeal is exhausted and fails, the Affordable Care Act federally guarantees your right to escalate your case outside the walls of the insurance company. An independent medical review board, staffed by doctors who do not work for your insurer, evaluates the clinical evidence, and whatever that independent board decides is legally binding on the insurance company.
I love that. You rip the decision-making power out of the hands of the corporation trying to save money. But let's look at the numbers. What are the actual odds of a patient winning this bureaucratic war?
This is perhaps the most important, empowering statistic of this entire deep dive. According to the data in your sources, when patients actually fight back and navigate the appeals process, between 40% and 60% of all appeals are eventually overturned in the patient's favor.
Let that sink in for a moment. Up to 60% of the time, the insurance company's initial no was medically or legally wrong.
Exactly. More than half the time, they are denying claims they are contractually obligated to pay. The appeals process is not a suggestion. It is a required weapon. Fighting back works. You cannot accept the first no.
All right, we are project managing like seasoned professionals now. We understand the bills, we know how to appeal. But as we continue through the source material, there are massive areas in the American system where traditional insurance coverage simply stops existing. It just falls off a cliff. I want to transition to what happens when you age, when you need dental care, or when you decide to leave the country entirely to get fixed.
Let's start with aging, because this is a demographic cliff every single listener will eventually face, either for themselves or when managing care for their parents. Elder care and the transition to Medicare.
Medicare is notorious for being an alphabet soup of confusion.
Yeah.
Can you break down the mechanics? Why is it fractured into so many different parts?
The fragmentation is a result of the historical political compromises made when Medicare was enacted in 1965. It is the federal health insurance program primarily for people 65 and older. It is divided into 4 main parts. Part A covers inpatient hospital stays, hospice care, and very brief stints in skilled nursing facilities. For the vast majority of Americans who have paid Medicare payroll taxes during their working years, Part A is premium-free.
Okay, so Part A is the hospital building itself. What about the regular doctors and outpatient clinics?
That is Part B. Part B covers outpatient medical services, regular doctor visits, lab tests, preventative screenings, medical equipment. Part B is not free. It requires a monthly premium, which is deducted directly from your Social Security check. It's around $174 a month for most people, though it scales up significantly if you have a high retirement income.
And Part D, I assume D stands for drugs.
Yes. Part D was added decades later to cover prescription medications. It is sold through private insurance companies approved by Medicare. Then, to complicate things further, you have Part C, which is widely advertised as Medicare Advantage.
I see ads for that everywhere.
Yes. This is an alternative pathway where you opt out of traditional government Medicare and instead buy a comprehensive plan from a private corporation that bundles Parts A, B, and usually D together into one package, often adding some extra perks like gym memberships. However, the major trade-off is that Advantage plans require you to stay within a strict, limited network of doctors, and they heavily utilize the prior authorization denials we just discussed.
So that outlines what the alphabet soup covers. But your notes highlight the dangerous gaps. What does Medicare not cover that completely blindsides seniors?
The gaps are shocking, and they represent massive out-of-pocket liabilities. Traditional Medicare does not cover most routine dental care or dentures. It does not cover vision care or eyeglasses. It frequently does not cover hearing aids. It does not cover medical care received outside the borders of the United States. But the most dangerous, financially devastating gap of all is that Medicare does not cover long-term custodial care.
We need to define custodial care clearly. How is it different from medical care?
Medical care is a nurse administering IV antibiotics or a physical therapist helping you walk after a stroke. Medicare covers that. Custodial care is non-medical, daily assistance with the basic activities of living. Bathing, getting dressed, eating, using the bathroom safely. If you develop severe Alzheimer's disease or simply become too frail to live independently, you require custodial care, often provided in a dedicated nursing home or via a full-time home health aide.
And Medicare won't pay for that.
Medicare will pay for a short rehabilitative stint in a facility immediately following a hospital admission. Remember the 3-day inpatient rule we discussed earlier. But they will absolutely not pay for you to reside in a nursing home for 3 years because you have dementia.
What does a nursing home actually cost in the U.S. if you had to pay out of pocket?
It is a profound, slow-moving crisis. A semi-private room in a nursing home currently averages $80,000 to well over $100,000 a year, depending on the state.
$100,000 a year. That will drain a middle-class family's entire life savings, the equity in their home, their entire retirement account, in a matter of months. What do people actually do when they hit this wall?
If you are confronting this for aging parents, you are forced into incredibly complex, often heartbreaking financial maneuvering. There are really only 2 paths. You either had the foresight to purchase expensive long-term care insurance decades in advance, or you must consult with specialized elder law attorneys to engage in a process called Medicaid planning.
Medicaid. But you mentioned earlier that Medicaid is the program for low-income individuals.
Yes, because unlike Medicare, Medicaid does pay for long-term custodial nursing home care. In fact, Medicaid is the largest payer of nursing home care in the nation. But you only qualify for Medicaid if you are virtually impoverished. Your total assets must be grained down to a few $1,000s. So elder law attorneys help families utilize legal trusts and asset transfers to structure or spend down their life savings so the aging parent can legally qualify for Medicaid coverage before they are completely destitute and the healthy spouse is left bankrupt. It is an agonizing legal maze.
If your parents age into this system, you are going to be the one forced into this complex financial maneuvering. You are the one who will have to hire the elder law attorney. It is a family crisis, not just an individual one. Let's pull back from the elder care cliff and examine another massive gap that affects people of all ages. Teeth.
Yes.
Let's talk about dental emergencies. Why on earth are teeth treated like luxury bones completely outside the medical insurance system?
It is a fascinating, frustrating historical quirk. In the 1840s, the first dental college was established in Baltimore because the existing medical schools explicitly rejected dentistry, viewing it as a mere mechanical trade rather than a medical science. That early schism calcified over a century. As a result, the medical and dental professions evolved separately, with separate licensing, separate lobbying groups, and entirely separate insurance structures.
And the result today is that standard health insurance rarely covers dental care, and standalone dental insurance is notoriously terrible. Most dental plans cap your annual benefits at $1,000 or $1,500 a year. If you need a single root canal and a crown, you blow through your entire year's coverage in one afternoon.
Exactly. So what happens when a crisis hits? What happens if you wake up on a Saturday morning with a massive, throbbing, blinding tooth infection and you don't have thousands of dollars in your checking account? Can you just go to the medical ER?
I assume they have to help you if you are in agony.
You can go, but you must deeply understand the ER's clinical limitations. Hospital emergency rooms are staffed by medical doctors, not dentists. If you present with a severe toothache, they can diagnose the abscess. They can prescribe heavy antibiotics to stop the infection from spreading to your bloodstream or your brain, which is vital, and they can give you temporary painkillers. But they cannot fix the underlying structural problem. They cannot perform a root canal, and they generally will not extract the tooth. They will stabilize you, hand you a massive ER facility bill, and tell you to call a private dentist on Monday morning.
So the ER is just a very expensive Band-Aid for dental issues. What are the actual practical hacks for surviving major dental costs when you don't have good insurance?
You have to step outside the traditional private practice model. First, aggressively look for university dental schools in your region. Dental students, who are closely supervised by expert veteran instructors, perform comprehensive procedures at significantly reduced rates. It takes longer because everything is double-checked, but the savings are immense.
What else?
Second, seek out federally qualified health centers, or FQHCs. Many of these community clinics have dental wings that operate on a sliding scale fee strictly based on your income.
And what about those dental discount plans I see advertised? Are those a scam?
They are not a scam, but you must understand, they are not insurance. They are membership programs. You pay an annual upfront fee, perhaps $150 or $200 a year, and you gain access to a specific network of participating dentists who have contractually agreed to heavily discount their cash services by 10 to 60% for members. The advantage is there are no deductibles, no waiting periods for major restorative work, and no annual maximum caps. If you need $10,000 worth of extensive restorative work, a discount plan is often mathematically vastly superior to traditional dental insurance.
That is a phenomenal hack. Let's look at one more structural gap before we move on. The student to adult transition, the aging out cliff.
Yes, the age 26 provision.
The Affordable Care Act gave families a great safety net. Young adults can remain on their parents' employer-sponsored health insurance plan until they turn 26, even if they don't live at home or are married. But what actually happens on that 26th birthday?
You age out. You are officially kicked off the parental plan. This termination is a qualifying life event, meaning you now have that 60-day window to navigate the marketplace and buy your own insurance if you don't have a job that provides benefits. And for international students studying in the U.S., the transition is even more precarious. When your student visa grace period ends, your university-sponsored health insurance terminates immediately. If you were staying in the U.S. for an extra month to travel Route 66 or visit the Grand Canyon before heading back to your home country, you must proactively purchase international travel health insurance. Do not let your coverage lapse while doing a road trip in America.
Which brings us to the ultimate, darkly humorous irony of the American healthcare system highlighted in the research: reverse medical tourism.
It is a massive, rapidly growing, multi-billion-dollar industry.
We have a system so expensive that American citizens are literally fleeing the country to get medical care. It is often mathematically cheaper to buy a round-trip international flight, stay in a nice hotel for 2 weeks, and pay cash for a major surgery abroad than it is to use your own premium health insurance in your own hometown.
The cost differentials defy logic. You mentioned a dental crown earlier. A complex crown that costs $1,500 out of pocket in a U.S. clinic might cost $300 in a state-of-the-art, pristine clinic in Mexico or Colombia. A major joint replacement, like a knee or a hip surgery, that could cost a patient $40,000 out of pocket in the US might cost $10,000 in Costa Rica, and that price often includes the surgery, the hospital stay, and 2 weeks in a resort-style physical therapy recovery facility.
But there are massive inherent risks involved here, right?
Yeah.
We have all heard the horror stories. It's not just a tropical vacation with a surgery attached.
There are profound risks. The quality of care, the sterilization protocols, and the legal liability vary wildly from country to country and clinic to clinic. You have to be incredibly diligent. The gold standard warning from the sources is to only seek out facilities that hold JCI accreditation, the Joint Commission International. That accreditation means the foreign hospital is actively audited and meets the exact same global standards for safety, emergency protocols, and cleanliness as top-tier U.S. hospitals.
But what if the surgery is perfect, but you just have a bad biological reaction? What if a complication arises after you fly back home?
That is the ultimate catastrophic financial risk. If you get a botched surgery abroad or you contract a severe drug-resistant infection and you have to fly back to the U.S. and go to your local ER for emergency corrective care, your American health insurance will almost certainly refuse to cover the costs. They will argue that the life-threatening complication arose directly from an elective, out-of-network, out-of-country procedure that they never authorized. You have zero safety net. Medical tourism requires intense, obsessive research and a clear-eyed acceptance of the worst-case scenario financial risk.
We're entering the final stretch of this deep dive. We've talked extensively about the mechanical forces of the system, the billing errors, the insurance networks, the legal loopholes, but your stack of sources pushes us to look at the invisible forces that shape our medical choices. Let's look at the intersection of culture, information, and personal autonomy, starting with the most pervasive force of all, the internet.
Combating health misinformation is perhaps the most critical foundational survival skill of the 21st century patient.
We have all fallen victim to it. You get a weird rash on your arm or a twitch in your eyelid, you open up Google, and within 15 minutes of scrolling, you have confidently diagnosed yourself with a rare tropical parasite or stage 4 cancer. Dr. Google is an absolute menace to our collective anxiety.
It represents a double-edged sword. It is the democratization of medical information, which is wonderful for patient empowerment. But it is combined with a total lack of contextual clinical filtering, which is incredibly dangerous. The internet is a fire hose of pseudoscience, targeted supplement ads, miracle cures, and anecdotal panic.
So how do we actually filter it? If I have a symptom and I want to research it before my appointment, how do I find the signal in the noise? You've distilled 5 guidelines for truth from the research.
Guideline 1, stick exclusively to authoritative institutional domains. If you are researching a symptom, you must bypass the lifestyle blogs, the wellness influencers, and the forums. Go straight to the primary sources, the CDC, the National Institutes of Health, the World Health Organization, the Mayo Clinic, or peer-reviewed medical journals like The Lancet or the New England Journal of Medicine.
Guideline 2 addresses the influencer problem directly.
Yes. Reject anecdotal evidence. A viral video of a charismatic person saying, "I drank a cup of apple cider vinegar every morning and my tumor magically shrank," is not clinical data. Individual unverified experiences do not equal medical efficacy.
Which leads right into Guideline 3, the red flag of miracle cures.
If a website or a podcast claims that a single, secret, proprietary product can simultaneously cure diabetes, reverse aging, and cure arthritis, and they happen to be selling that exact product for $49.99 a bottle, well, it is a scam. Human biology is infinitely too complex for magic bullets.
Guideline 4 is about understanding how science actually works.
Yeah.
Seeking consensus.
Exactly. Look for the broad medical consensus. Science is a slow, methodical, collaborative process. If 99% of global epidemiologists agree on a specific vaccine protocol and one fringe suspended BAMPter has a YouTube channel claiming they're all part of a massive conspiracy, bet your life on the 99%. Consensus is the closest thing we have to objective medical truth.
And Guideline 5 is the most practical step for the project manager.
Bring your digital research into the real physical world. Print out the peer-reviewed articles you find. Take them to your actual doctor, slide them across the desk and say, "I read this study regarding my symptoms and I'm concerned. Can we discuss how this data specifically applies to my unique body?" Safely bridge the digital information with professional, individualized medical context.
That brings us to our final topic before we synthesize all of this, the cultural crossroads of U.S. healthcare. Because the medical system in America isn't just a cold set of bureaucratic rules, it carries its own distinct, deeply ingrained cultural biases. And these American biases can heavily conflict with the diverse cultural backgrounds of the patients trying to navigate it.
It creates profound, often invisible friction in the exam room. Let's look at a few common examples from the sociological data in your sources. The first is the fundamental approach to healing itself. Medication versus natural remedies.
U.S. medicine is notoriously interventionist. We are heavily reliant on pharmaceuticals. You present a problem, the system generates a pill to fix it.
That is the American paradigm. Whereas many cultures globally, particularly East Asian, South Asian, and various Latin American cultures, often possess a strong, deeply rooted preference for natural, herbal, dietary, or holistic remedies as the first line of defense against illness. This dichotomy creates a silent, destructive conflict. An American doctor prescribes a daily statin for high cholesterol. The patient, adhering to cultural politeness, smiles, nods, takes the prescription slip, and then throws it in the trash when they get home because they intend to try dietary modifications and traditional herbs first.
Which completely ruins the doctor's ability to actually treat them because the doctor assumes the patient is taking the medication. What is the solution to that silent standoff?
Open, upfront dialogue regarding cultural preferences. Patients must be empowered to say, in my culture, we prefer to try lifestyle modifications or non-pharmaceutical approaches first before starting a daily medication. Can we start there, monitor my blood work for 3 months, and reassess? American doctors are increasingly trained to be open to this collaborative approach, but they cannot monitor your progress or check for dangerous herbal interactions if you are hiding your actual behavior from them.
The second cultural conflict is massive, and it deals with legal authority. Autonomy versus family.
This concept is deeply embedded in the bedrock of U.S. medical law. In many cultures around the world, severe medical diagnoses like terminal cancer are handled collectively by the family unit. Sometimes the patient isn't even told the severity of their own illness. The family patriarch or the eldest children act as a shield. They receive the bad news from the doctor and make the treatment decisions to spare the sick patient the emotional burden.
But if a family tries to enforce that dynamic in an American hospital,
it clashes violently with U.S. law. In the U.S., the legal and ethical framework strictly enforces the concept of individual patient autonomy. The individual patient is the absolute, unquestioned authority over their own body. An American doctor is legally and ethically bound to disclose the diagnosis directly to the patient, regardless of how much it upsets the family. Furthermore, the doctor must take medical direction solely from the patient, even if the entire family vehemently disagrees with the patient's choice to stop chemotherapy.
That must cause incredible tension and shouting matches in hospital hallways.
It frequently does. Social workers are often deployed to mediate these exact disputes. But legally, the individual's informed consent is the only consent that matters in the United States, as long as the patient is mentally competent.
What about the cultural stigmas surrounding mental health and gender preferences?
These are also areas requiring clear, assertive communication. In many cultures, seeking mental health care carries a severe, shameful stigma. It is viewed as a personal weakness or a spiritual failing rather than a biological issue. American medicine attempts to treat mental health as equal to physical health. Normalizing therapy and psychiatric care and deeply understanding the strict, legally binding confidentiality laws protecting those therapy records is vital for cultural integration.
And requesting a physician of a specific gender.
That is an absolutely valid and legally protected right. Many cultures and many religions have strict modesty norms. If you require a female doctor for a physical exam or for childbirth, you do not need to apologize for it. You simply state that non-negotiable requirement when booking the appointment. The American system accommodates this routinely, but you must ask for it upfront.
And finally, the cultural approach to the end of life.
Death is handled very differently across cultures. Some view discussing death as inviting bad luck, but American medical ethics heavily emphasize aggressive pre-planning and informed consent at the end of life, which means utilizing specific legal documents to project your autonomy into the future. Advanced directives, living wills, and designating a healthcare power of attorney.
So you dictate in writing, if I am in a coma and reliant on a ventilator, do this, but absolutely do not do that.
Exactly. It establishes your voice and your legal authority even when you lose the physical ability to speak.
Okay, we need to pull all of this together. We have covered an immense amount of ground today, analyzing the system from every angle. Let's synthesize the data. Let's do the ultimate rapid-fire summary. What is the core ethos of our survival manual?
First, Always verify your networks, both the doctor and the facility, before receiving care. Second, understand the math and ruthlessly scrutinize your itemized bills. Remember the 80% error rate. Third, aggressively appeal your insurance denials using letters of medical necessity because you have a massive 40 to 60% statistical chance of winning. Fourth, never go a single month uninsured during an employment transition. And fifth, utilize highly specific clinical vocabulary and proactive questioning to command the exam room.
You are the project manager of your body. You are the CEO of your biological portfolio. But that brings me to a final, slightly uncomfortable thought. Something I want you, the listener, to really mull over as you digest everything we've talked about today. Throughout this entire deep dive into the source material, we have hammered home this central idea. To survive the American healthcare system, you must be a highly alert, persistent, aggressive advocate. You have to hunt down those 80% billing errors. You have to write detailed letters to overturn algorithmic appeals. You have to forcefully question the observation status in the ER while you are in pain. You have to audit your EOBs.
It requires an immense, exhausting cognitive load.
Right. So here is the provocative question I want to leave you with. In a system that relies so heavily on you being awake, alert, and ready to fight bureaucratic battles, well, what happens to you when an unexpected accident leaves you too sick to manage the project? What happens when you are in a medically induced coma or intubated in an ICU or simply in too much agonizing pain to argue with a hospital billing department over your admission status?
That is the terrifying cliff edge of the entire system.
Yeah.
When the project manager is incapacitated, the project fails.
We just touched on advanced directives and healthcare proxy documents. People instinctively think those forms are just for the elderly or for people who have received a terminal diagnosis. They aren't. A drunk driver can cross the center line at any age. A severe stroke can happen at any age. So my challenge to you right now, while you are healthy, while you have your full cognitive faculties and you are listening to this, is to go set up your personal healthcare board of directors. Assign your healthcare power of attorney today. Sign the documents. Ensure that if tomorrow brings a sudden medical crisis where you cannot fight this incredibly complex, profit-driven system yourself, you have legally empowered a trusted ally who will fight it for you. Because remember our opening scenario. That clean, simple x-ray where the doctor just fixes the problem doesn't exist in the administrative world. You aren't just buying a car blindfolded. You are navigating murky, dangerous waters. You need someone legally authorized to take the wheel when you can't.
Preparedness, codified in legal writing, is your greatest shield against a chaotic system.
Thank you for joining us on this massive, comprehensive deep dive into the source material. Take this information, process it one step at a time, implement the strategies, stay empowered, and own your healthcare journey. We will see you next time.